with the evolving that happened, led to significant improvement in the management of hemophilia. In 1990, the first generation of recombinant factor VIII was developed. And then in 1994, the second generation, and third generation in 2003. And all this has led to significant improvement in the care of hemophilia patient. In 2014, where the significant improvement happened when the extended half-life factor VIII was developed and that led to a significant improvement in the care and also in the quality of life improvement of the patient. And in 2018, where the non-factor therapy, including emicizumab and other treatment was developed, and that also led to significant improvement in the care of the hemophilia patient. Okay, so our aim in the treatment of hemophilia is health versus safety. Our aim is to minimize the bleeding rate over the year, and also improve the function of the patient. So in hemophilia A, there is factor replacement, and this is our mainstay of therapy. And non-factor replacement was available now in the market is emicizumab. I will focus on factor VIII now. Factor replacement means prescribed or as a prophylactic or in demand when the patient develops bleeding, or sometimes combination between prophylactic and on demand as well. Clotting factor in general is manufactured as factor VIII concentrate given via IV infusion, either plasma derived or recombinant. Prophylaxis is the mainstay of and the gold standard of the treatment of hemophilia patients. Is indicated for all patients with severe hemophilia. It's given as a regular scheduled dosing, typically ranging from every other day to every 2 to 3 weeks. Determined based the doses and the interval determined based the weight of the patient, and also individual drug metabolism, the pharmacokinetic monitoring. The benefits include reducing the number of bleeding episodes and also joint protection, and that has been well established in so many clinical trials. While on-demand approach is as needed dosing infused based on anticipated activity level, or in case of active bleeding, those around procedures. The benefit of prophylaxis has been established. So many clinical trials. The joint study was one of the landmark study that has been shown that the prophylaxis approach not only reduce the risk, the number of episode of hemarthrosis, also improve the outcome. I mean, based on MRI studies, the normalization of the radiological manifestation of the joint as well in the long term of use of prophylaxis. So, as I mentioned, is the standard of care, frequency of infusion maintenance, maintain the factor VIII level more than 1%, with a standard half-life replacement can like protect against hemarthrosis or bleeding in general. The half-life of the most of the recombinant factor 8 is ranged from 8 to 12 hours, which really makes this approach a little bit adding another burden on the patient and also the health care as well, resources. Infusion every 4 half-lives means that the patient will need the prophylactic dose every 48 to 72 hours. Challenges, as I mentioned, requires frequent intravenous infusion. Also, difficult to maintain adequate trough level, which is very important to keep the trough level roughly more than 3% to prevent, in order to prevent spontaneous bleeding. Also, the compliance of the patient will be affected. I mean, most of our patients, they don't feel comfortable to come to the hospital or to receive injection in like every 48 hours. Here the trough level and the annual number of joint of bleed. So we need, as you could see here, if the trough level less than 3%, number of joint bleed will increase. So very important to keep the trough level of the factor 8 more than 3%. So we need to improve our prophylaxis, definitely approach. Like we need prophylactic that require less infusions, means longer half-life. Also, we need higher factor trough level. We need the factors or that maintain the trough level more than 3%. Also, if possible, then IV administrations will be more convenient to the patient, and that will also improve the adherence to the prophylaxis. So, as I mentioned, as WFH guidelines 2020 recommend target higher trough level more than 3% to 5% or higher in order to prevent spontaneous bleeding. So here to come were the extended half-life replacement that was first published in 2014. There are two approaches to extend the half-life of the factor 8. Number one is IgG FC fusion approach. And number two is the pegylations of the factor 8. Modification to prolong half-life, as I mentioned, the number one is FC fusion and addition of albumin protein. So uses IgG FC receptor pathway to escape the lysosomal degradations. Number two approach is pegylation, which is addition of polyethylene glycol molecule to reduce binding of clearance receptor. So the big molecules is too big to be cleared by the kidney. That makes reduce the clearance of the factor 8. And also big factor 8 does not bind well to clearance receptor in the liver as well. Also, another approach is site-specific pegylation, preserve coagulant activity and binding to vulnerable factor. And that by doing this, also the big molecule is cleaved up in factor activation. With that, that will not affect the function of the factor 8. Albumin fusion with the recombinant albumin is another way to extend, to improve the half-life of the factor 8. By doing this FC fusion or pegylation, that will improve the half-life by decreasing glomerular filtration due to increase the hydrodynamic volume, also decrease receptor-mediated clearance of big attached clotting factor, also will decrease proteolytic degradation of big attached clotting factor molecule. So the benefit of extended half-life, decrease in fusion frequency, reduction of treatment burden, that will potential to improve adherence and reduce bleeding complications from missed doses. Also, ability of higher trough level schedule that will lead to better bleed prevention, lower annual bleeding rate. Definitely will improve also quality of life, and also that will reflect on the patient care as well eventually. So we have to be careful which patient who most likely will benefit from the extended half-life. Usually we consider in patient extended half-life in patient who has difficult venous access, poor adherence to the prophylactic doses of factor VIII. Also in patient who need for higher trough level to be maintained. Also the bleeding event or appropriate dose of a standard half-life product. We have 4 approved products of extended half-life, either recombinant, pegylated, or by using FC fusion. Number 1 is Hematology. Alpha is the recombinant factor VIII with half-life is 19 hours, and it has been approved either on demand or in a prophylactic approach, usually given in 50 units per kg every 4 days, or 25 to 65 units per kg every 3 to 5 days. The second one is Hematology alpha is a pegylated one. The half-life has improved 14 to 16 hours. And also the same approval on demand or prophylaxis with the dose of 40 to 50 units per kg twice weekly. The third one is the Hematology alpha is a pegylated one as well, with the dose of 30 to 40 units per kg. And the half-life is 17 to 21 hours. Those are the most that available in the market. The efficacy is of extended half-life has significantly improved. I mean, the half-life, as you see, like for Hematology is around 19 hours. And the half-life has improved by 1.2 to 1.5 times more than the regular or the usual factor VIII. And with the APR, the annualized bleeding rate also has improved as well. Treatment of bleed during breakthrough, most of the patient, the bleed has stopped by only single dose, around 85%. And also in some the product, the bleed has stopped 90% or 95% the bleeding has stopped by giving the second dose of the extended factor. So as I mentioned, extended half-life product increased the half-life 1.5 to 1.7 fold with 30% reduction in number of infusion, with the range of half-life range from 12 to 19 hours. The product's able to maintain trough level 2 to 3 international units per deciliter, which was recommended in order to prevent spontaneous bleed. So we choose the which factor to be replaced as a prophylactic based on the phenotype of the bleeding, the adherence of the patient, the age and the venous axis, and also activity type and the pattern, and also time of infusion. It's very important. The monitoring is very critical in those in these new factors. One stage ABTT versus chromogenic assay. So you have to know for each product there is a certain way to measure the ABTT. And this is very important to know that. Not only dealing with the factor, but you have to know your resources in the lab. For example, which based on the product you have to make sure that the ABTT measures in the right way. So I will move to non-factor therapy. As the most important is, as you could see here, so emicizumab. Emicizumab is a recombinant antibody, mimics the factor 8 activity, and that has been proven as a prophylaxis to prevent or reduce frequency of bleeding episode in adult and pediatric patient with or without inhibitor. The dosing is start with the loading dose of 3 milligram per kg weekly for doses, and then maintenance dose 1.5 milligram per kg weekly, or 3 milligram per kg every 2 weeks, and then 6 milligram per kg every 6 weeks. And you could see here by emicizumab has maintained the factor level, the trough concentration over time in a good range. So many trials, like we have Heaven 1, Heaven 2, 3, and 4, that led to approval of emicizumab as a prophylaxis in patient with or without inhibitors. And you could see here the annualized bleeding rate has been significantly reduced with emicizumab in a range of 87% in the Heaven 1 trial. And also in Heaven 2, where patients with inhibitors were enrolled, emicizumab has proven that there is a significant reduction in the annualized bleeding rate. There was no significant adverse event. There was no death or any other significant complication to the emicizumab. And there was some concern about, especially in a patient without inhibitors, in thrombotic events. But this is not, with the long-term follow-up, there was no significant complication was observed in the emicizumab group. So I'll go through the recommendations, different recommendations for patient regarding emicizumab for patient with hemophilia A with an inhibitors. The WFH recommended that emicizumab should be used for regular prophylaxis. Also, other society recommended that the same recommendation, that emicizumab also should be used as first-line prophylaxis.
2 minutes.
Okay, yeah, almost done. So with no inhibitors, WFH recommend for patients with hemophilia A with no inhibitors, emicizumab can be used for regular prophylaxis. The same recommendations also was made. So the consideration of using emicizumab, you have to be tailored based on the patient, the phenotype of the bleeding, also the adherence and the venous access as well. Other product was targeting the fitasterine, targeting SNN factor, was published in Atlas in open label phase 3 trials. Severe hemophilia A or B without inhibitors also has led to reduce the annualized bleeding rate in a range of 90%. With that, I think so. Yeah, there was no efficacy safety concern on this medication. With that, I will conclude. Thank you.
Thank you, Dr. Murray, for this excellent presentation. And the question will be at the end of the session. So next presentation is by Dr. Firas Al-Freih, treatment of elderly patient with AML. Dr. Firas Al-Freih is a consultant hematologist at King Faisal Specialist Hospital. He is the president of Society of Blood Disorders, and also is the director of Stem Cell Bank. So Dr. Firas, please, you can start your presentation. Thank you.
Assalamu alaikum. Good morning, everyone. So I would like to thank the organizer for the invitation, and I would like to apologize for not being able to be with you today in person. So in the coming 30 minutes, I will be trying to address management of older or unfit patient with AML. This is my disclosure. The outline of my talk will be, we will be addressing some definitions and epidemiology, biology of AML in older adults, and how to assess medical fitness of patients. Then the last part will be the management of older AML / unfit patients. So I will start with a question, just to stimulate the audience. Is what is the definition of older adults? Is it patient above 60, above 65, 70, or 75 years old? We'll try to address the right question in the coming slides. So in clinical practice guidelines, because there will be different definitions, however, in healthcare, there is no adequately defined cutoff for elderly people. If you look into the ISMO guidelines, they use 70 years old as a cutoff for geriatric oncology. However, if we want to talk specifically about acute myeloid leukemia, 60 years is the most frequently used cutoff age. Please be remember, even for older adults, they are subclassified into 3 categories: young older adult, middle old, and very old. However, I would like to bring to your attention the term elderly is not the right term. In 1995, the UN Committee on Economic, Social, and Cultural Rights of Older Persons rejected the use of the term elderly, and they recommended to use the term older persons. Although you will see several, I would say many publications using the right term, however, this is not the case. You will be surprised to see elderly as a term being used in some respected journals. This led in 2011 to the editor-in-chief of Geriatric Physical Therapy to put the following statement: it is time our language use matures, using terms that are precise, accurate, value-free, and that older adults prefer makes a good sense. The term older adult or older person is respectful and should be the standard term in this journal. Moving on to the epidemiology of leukemia. So if you look into one of the important publications about the leukemia incidence between different continents, it is not surprising that there will be a variation of the incidence. This is even after standardizing the age. The highest incidence is in the North America with 8.7 cases per 100,000, and while the lowest is in Africa with 3 cases out of 100,000. The obvious reason is we unfortunately do have underdiagnosis of some cases in different parts of the world. Moving for AML specifically, it's a disease of older adults. The median age at diagnosis is 68. And if you look specifically for those who are above 55 years old, they count the majority with approximately 75 of the cases. They compromise all population. However, this is in North America database. In our country, very likely it will be younger. In Saudi Arabia, the life expectancy is increasing over years. In 1990, it was 70. It was 70 for males. In 2016, it's increased to 75. The same thing for female, increased from 73 up to 79. So what I want to say that we have a growing population of older adults, though the population pyramid shows that we do have very young population. However, into those who are above 60 years old, approximately we do have close from 1 million population in the country. If you look specifically into the global burden of diseases in Saudi Arabia, which is a dynamic, which is data that get published by IHME and updated regularly. So if you look at the burden of cancer in general, which is this part for the population between 50 to 69, it accounts for significant number of deaths. If you look into comparison for all ages, it's approximately half of it, and the same thing applies for leukemia. Leukemia as a cause of the death for people between 50 to 60 versus all ages. So what I want to emphasize that it is an important contributing factor for death, and that's why we should try to offer treatment for all ages. Moving to some local data. So in the annual Saudi Cancer Report, the number of incidents of cancer in Saudi Arabia was reported 70 versus 37, which versus 370 in Australia. Is it true we have a lower incident, or we still have some challenges when it comes to diagnosis? The answer to that question is not known. However, based on the annual Saudi Cancer Report, approximately we have yearly around more than 100 newly cases older adult with acute myeloid leukemia. Switching to the biology of the disease, and if we look into the 5-year survival of AML across different ages, we do see significant improvement between 19. So the blue line represents the era from 1970 till 1980, and the purple line represents the era from 1997 to 2005. If we look at the improvement in the survival, we see there is significant improvement for those who are 18 years and younger. Same thing happens across other age groups. However, when we move to the older adult, the improvement is very dismal, and the survival in this report shows very dismal outcome. If we look at the data in a different, from a different view, AML mortality by age. So if we look at all the mortalities of AML across all the ages, we find that 70% of mortality happens in those who are above 65 years of age. So why do we have a poor survival of AML in older adults? So first important point is that this group of patients, they do have a poor prognostic features. There are several studies have confirmed this. So this is one of the earlier studies that was published in 2006, showed that those who are above 75, they do have a approximately 50% of AMLs with unfavorable versus 35% for the younger patients. So if we look into the overall survival in the same paper for different age group. So if we look at the favorable, so we understand that older adults, they do have a higher unfavorable cytogenetic. However, for those with a favorable risk cytogenetics, their outcomes was very low in compared to the other age group. When it comes to the unfavorable cytogenetic outcome for all age groups are I would say dismal for all of them, and there is no significant difference. When we look into also the outcome for intermediate risk, again, that the outcome of overall survival is much lower than those who are less than 56 years old. So we cannot find a good reason why this group of patients, they do have very bad outcomes, even for favorable and intermediate risk AMLs. Is there any other contributing factor? So one important contributing factor was physician attitude toward intensive chemotherapy. So in this important paper from Sweden, they looked into the intention to treat AML across 6 regions in the country. And they categorized them into different ages. So they found those who are less than 60 years, the intention to treat more than 90% in all the 6 regions. However, as the patient goes older, we start to find some differences, especially above 70 years old. It was clear that there are 2 regions. Their intention to cure AML is above 70%, while in 2 other regions it is less than 40%, and the same thing goes also for above 80. So different in practices in different regions in this paper was very important, and showed that intention to cure varies based on the physician discretion. So in the same paper, they looked at the overall survival based on the risk, and the risk for those who are above 70 to 79. It did vary. So if the patient in a region with a high intention to cure rate, the survival at 1 year is close from 40% versus 20% if you are in a region where intention to cure for older adult is low. Same thing is after a longer period of follow-up, which is 5 years, there is significant variation in the overall survival between the different regions. Where the death is higher in this study, so they categorize the patient into two groups: one who received the intensive versus the one who received the palliative, and then they added the performance status, and they risk stratify them according to the age. So not surprisingly, that the early death in AML increased with the higher age, regardless of the performance status. However, if you look into the intensive into the group who received intensive treatment versus palliative treatment, so it is important to highlight actually the difference in the palliative arm was much higher versus those who received intensive care. This happened for those with an excellent performance status, and the same thing for those with a poor performance status. So yes, they do have a higher rate of mortality, but leaving them with no treatment definitely will result into worse outcome. So the authors of this paper stated, we suggest all AML patients younger than 80 years with specific contraindication to be offered hematological evaluation and considered for remission induction. Switching, so how to assess medical fitness? There are several assessment tools. The two important tools when we want to decide whether a patient fit or not fit is one, physical or functional assessment. Two will be a cognitive assessment, which is important for this group of patients. The famous one is the ECOG. Other tools is ADL, IADL, and in short, physical performance battery. So in this paper, they looked into variation between ECOG and the proper tool used by geriatrician to assess older adults, and the answer is yes. So the rate of patient with low with ECOG 0 to 1 doesn't mean that the patient is fit for treatment. Here they looked into different tools using IADL, ADL, or SPPB. So what I would like to emphasize that performance status or ECOG lacks sensitivity enough to differentiate patients with subclinical vulnerability from those who are fit. SPPB takes approximately 10 minutes to be completed. It consists from assessment for lower extremity strength, chair standing, gait speed, and there are several electronic calculators to help you in calculating it. This is the category. It will be between minimum limitation to severe limitation. When it comes to the cognitive assessment, 3M is more of validated screen tool to assess global function, global cognition, and and it's considered to be impaired if it is less than 77. There are other important factors, though they are important, but I would say less important than the first two, which is the cognitive and the physical assessment. The other factors include nutrition, social support assessment, presence of comorbidities also is important, as well as psychological assessment. So this is an important study looked at geriatric assessment to predict survival in older adult AML during induction. And clearly it did show that 3M was an important predictor for older adult as well as SPPB. They did also multivariate analysis, looking at our usual risk stratification, whether it is cytogenetic, the age, and again in the multivariate analysis, 3M and SPP has been found to be independent risk factor for the outcome. So in the last slide in this part, I would like to emphasize that NCCN guidelines recommend periodic assessment for cognitive function or when considering changes to the treatment plan for all older patients, including those with no cognitive impairment. So in the last part, we'll switch how to treat AML, as well as for older ages. So there is no age cutoff. So we shall not use the age to define the type of treatment. It's actually more toward fitness, whether the patient is eligible for intense chemo versus non-eligible for intense chemo. If he is eligible for intense chemo, the recommendation is to use the standard induction, 3+7, plus minus targeted therapy according to the mutation, and to be followed by consolidation with RSC or PMT. For non-eligible, there are different regimens that shall be considered. Azacitidine is the most famous one, followed by low-dose cytarabine, dose targeted therapy, or to enroll patients in a clinical trial. The CR rate for this group of patients who received intense chemotherapy is high. Many studies have shown that it goes up between 60 to 65%. Same thing here. So this is important. Randomized prospective study. This is ECOG 2906. It confirmed that survival for the patient between 70 to 80 years old with intermediate AML, 60 to 65. Though the early death risk was 10 to 15, however, the chance of achieving long-term survival with negative MRD was 40% for those who received standard induction chemotherapy. Just would like on the same paper, they found this shall not be applied for high-risk AML, specifically monosomal karyotype, complex karyotype, or P53 mutations. Management of AML has evolved in the last several years. Now we do have many targeted therapy, FLT3 inhibitor, IDH inhibitor, Hedgehog pathway inhibitor, c-KIT, RAS, and PD-1 inhibitor. All has helped in improving the overall survival and the outcomes of such a group of patients. We have many approvals in the last 5 years. And there are actually some more. I have not added them in the list here. So important one is FLT3 inhibitor. We do have several agents as a FLT3 inhibitor. Midostaurin and gilteritinib are important ones for AML. And they received the US FDA approval based on overall survival advantage in compared to placebo. So in this study, midostaurin increased the survival from 25 months up to 74 for the arm who received midostaurin. At 12-month assessment, gilteritinib showed statistical significance in the improvement of the survival rate. IDH1 and IDH2 has been approved for relapse refractory AML. Glastig is a Hitchcock pathway inhibitor, which is approved for upfront AML above 75 years who are not eligible for intense. Although overall survival advantage increased from 4.9 to 8.8. And this is the same applies for all targeted therapy. This I would like to emphasize for those who are eligible and those who are fit, bone marrow transplantation shall be considered as a treatment option, as a consolidation treatment option. CBX35 is another treatment for therapy-related or secondary AML. It is a cytarabine and daunorubicin encapsulated. So one important medication, plus azacitidine, that is going to be also an important tool to for older adults or fit patient. Shall we use gemcitabine? Gemcitabine has shown significant improvement for favorable AML. However, several studies have shown adding it to older adults might likely to result in more toxicity than benefit, although there is no clear consensus, but the recommendation toward more careful of using it, I recommend not using it. However, there will be exception based on the patient assessment. PMT is another therapeutic modality for AML, and this report by CIBMTR, number of transplant done for above 60-year-olds is increasing, which is another way to say that chronological age shall not be used to determine the fitness for any treatment. For the sake of time, I will just skip some slide here for CAR-T. CAR-T for AML is an important treatment with a very long list of ongoing clinical trials. In this, in a recent search, there are more than 300 papers on CAR-T for AML. Those are some selected clinical trials, phase 1, 2, and 3, using different targets, CD123, CD33, CD or dual CD38, 56, 123. Is CAR-T for older adult? The tolerance for CAR-T is different. We try to, although this is a multi-center study, although it is in lymphoma. However, the conclusion of the author that the tolerance for CAR-T between elderly, geriatric, and younger patients, indicating that age per se should not preclude CAR-T cell administration. So, in summary, how would you treat diagnosed AML? So, in my recommendation, it will be the assessment based on the fit versus unfit. For older adult AML, there is a special group which is a complex monosomal or with mutation P53. In this group of patients, hypomethylating agent plus venetoclax shall be used for older adult AML over intense chemotherapy. For fit older adult AML, intensive chemotherapy plus targeted therapy shall be other option is CBX35. For unfit therapy, it will be the recommendation is hypomethylating plus venetoclax plus IDH1 or 2 inhibitor based on the mutation. For relapse refractory, there is recommendation is to avoid intense chemo and to go toward less toxic treatment with hypomethylating plus minus venetoclax or other agents plus targeted therapy. So, in conclusion, global inequality in survival from AML have narrowed with time, but still remain deeply wide. Abandonment of treatment for older AML is a major issue. Sometimes chronological age is less important than biological events in driving aging process. review current practice and management of AML in older adults is warranted at the level. And I would like to thank you for listening.
Thank you, Dr. Firas, for this very excellent and comprehensive presentation, focusing on approach to patient with AML on this age group. So I use the term age group so not to نقع في المحظور. عموما the question will be at the end, but if you allow me, Dr. Firas, just to discuss the term of elderly. I think what you have mentioned is very nice to respect this group of patients using the more appropriate term for them. But still, I think elderly is more specific term and more meaningful than older adult. And if somebody perceived aging process as negative thing, no word can make it better for them. Older adult is also insulting, elderly is so. I think older adult is more confusing. So the term of older adult in ALL is used to this for category of patient above age of 40. So based on the IA protocols at whatever, so they use adult and young. So I'm saying this just to relieve the pressure on Dr. Anas, so he can freely use the term elderly in his presentation. So if you have a say about this, Dr. Firas.
Thank you, Dr. Ibrahim. And what I think is important is the Arabic translation that we shall use. So this is what I would draw, that this is very important thing in the West. That's why the UN put a statement, what term to use. And I think we need to have a statement for what to use in Arabic for such a group of patients. Thank you.
I totally agree. Thank you so much. So our next speaker is Dr. Anas Hakim, who's a consultant hematologist at Prince Mohammed bin Nasser Hospital. His talk is about CLL management, especially targeted therapy. And until you use your own term, whatever you think is appropriate.
Thank you, Dr. Ibrahim. I would thank for my presentation today to allow me to present today. I was asked to talk about the targeted newly therapies of CLL, and I might have some interactive questions. I will start to present it. So based on current practice guideline, which of the following of BTKI-based strategies are considered to preferred category 1 recommendation for the managing patient with naive treatment of CLL without deletion 17p deletion disease? Is it all covalent BTKI, ibrutinib, acala, and zanubrutinib, or acala and zanubrutinib, ibrutinib, or acala, zanubrutinib, or pirtobrutinib? The second questions, and we are managing a patient with recent diagnosis of naive treatment and unmutated IGH, who presented with several comorbidities conditions, including renal insufficiency and history of hypertension. How would you manage this? Any covalent BTKI or ibrutinib, acala, venetoclax, or obinutuzumab? Third questions. You are managing an older patient with CLL and unmutated IGH who progress while on his frontline therapy with acalabrutinib. What would you do next? Switch to ibrutinib, switch to zanubrutinib, switch to venetoclax or non-covalent under clinical trial, continue therapy but with anti-CD20 antibody. The fifth question was your patient with symptomatic CLL and initiate therapy with acalabrutinib, and he responded well to treatment. During the first month, you note has development with therapy-related headache. How you would address this in event? Switch to zanubrutinib or switch to ibrutinib, use acetaminophen and caffeine, and or recommend a dose of interruption. The last question, which of the following pre-existing cardiovascular risk factor have been identified as a useful of informing treatment selection with the second generation BTKI in the wake of head-to-head trials with ibrutinib, a poorly controlled AFib, a poorly controlled AFib and hypertension, a well-controlled AFib, hypertension, heart failure, or valvular heart disease, or hypertension and heart failure. So to ask for this, the answer for these questions, now the last phase 3 recommendation, most of the studies was presented in the ASH 2022, was facing for patient who has upfront recommendation for the the 17p deletion. Without 17p deletion was to start with second generation, either Acala or zanubrutinib. For the second question answer regarding unmutated IGH new patient with several comorbidities. So whenever we have comorbidities, whenever we have try to avoid, especially this cardiovascular risk, try to start with second generation, because second generation has less side effects, especially elder and comorbidities. Switching venetoclax or non-covalent for patients who already was responding initially for more than 1 year, 2, 3 years on first generation of BTKI, and he relapsed. So switching to venetoclax and then covalent other BTKIs under clinical trial, this is the best option we have. And our patient with symptomatic Acala, usually they have 1 to 2 months, sometimes some symptoms of headache. We can use acetaminophen and symptoms relief, but sometimes if was persisting, we need to adjust the dose and making once daily and then resume it titrated to twice daily. The last question, the last answer for the last question with well-controlled, where the last study for the side effect profile was to make assessment for cardiovascular risk regarding the hypertension, heart failure, and valvular heart disease also as well. So I will start rush for my slide. So some slides I will skip it because of time. And this is the history for the FDA approval of BTKI. I think this is until 2020. And look how we use, how was to use the ibrutinib as a second line with 17 restricted for 17p deletion TP53 until we reach ibrutinib to be upfront. Here the without mutation, the first line without mutation deletion P17 from 2017 till 2020, in comparison how the expert and healthcare provider they started to initiate and they changed their practice from chemoimmunotherapies, while we're 59% in comparison with ibrutinib and 41% in comparison with the 2022 with mainly also venetoclax and obinutuzumab for this patient who have without negative 17p deletion. Here also with the 17p deletion, the same changes towarding the BTKI first and second generation, and avoiding especially the bulky disease. Here, as we see the bulky disease, from 2020 to 2022, the use of Acala and second generation started to be more because of side effects. So here the upfront line with the generation from 2017 to 2022 with 70p deletion. As we see here, 100% in 2017 were using ibrutinib with anti-CD20, and in comparison with 2022, where the experts were using BTKI plus anti-CD20 plus the BCL2 inhibitor obinutuzumab. I will summarize as much as I can the last ASH presentation for CLL, which were pointing for MRD negativity, which was not before for the previous studies, Clarity, Flare, and Captivate with the Glow. I will start with the Clarity study, who was presented in ASH with minimal residual disease less than 0.1 study endpoint, and secondary were showing after 6 months to 24 months for with ibrutinib and venetoclax. So the key exploratory was for BCL protein expression, and the inclusion criteria for a patient who has with 17p deletion after at least one previous therapy, performance, ECOG performance 012, and previous treatment with ibrutinib and venetoclax. Clear. Okay, for the schedule for scheme for that study, there will be 3 consecutive. Okay. However, see this one. Previous. Okay. So I will mention 3 consecutive MRD less than 0.1 CLL in peripheral blood confirmed in bone marrow, and with MRD less than 0.1 at 8 months. So stopping was ibrutinib venetoclax at 14 months with MRD negativity at 14 months, stopping ibrutinib venetoclax at 26 months, and MRD negativity less than 0.0 at 26 months, stopping at 26 months. If MRD positive, more than 0.01, continue ibrutinib till progression disease. If MRD positive more than 0.01 at 26, additional venetoclax for 12 months. So here the patient characteristic, I will skip, but they have all the subgroups, ECOG performance, lymph nodes, 8%, and Bennett was ABC, all of them were included. Here was the recommendation, single dose of tumor lysis at 200, they increased the dose. Recommendation also in the protocol was giving G-CSF to keep the neutrophil more than 1. And regarding the international working CLL responses was show the complete response and incomplete response was almost around 78%, and overall response was 92%. And as we see here, the duration is about 38 months. So the 5 years estimated with PFS 78%, and 5 years estimated overall survival was 91%. Regarding the progression-free survival was for IGH mutation was not significant, so almost they are almost the same. For this is the discontinuation, explanation, and progression of disease and of death. There were Richter transformation 4 patients, CLL progressed 3 patients, and MRD negativity reached to 53.1%. The conclusion for that study, clarity, MRD guided ibrutinib venetoclax duration of therapy result in improved outcome for relapsed refractory CLL patient. Estimated PFS and OS was in 60 months, during 60 months was 78% and 90% for overall survival. Outcome were similar as we see in IGH mutation and unmutated IGH as well. MRD responses continue to improve in the second year combination with ibrutinib and venetoclax. The initial rate of disease depletion is highly predictive for longer term responses to combination ibrutinib venetoclax treatment. The MRD guided duration ibrutinib venetoclax is being tested and in the phase 3 in the FLAIR trial, which we will come to see it next. Captivate trials was also the same idea, but with fixed duration. As we see here, the ibrutinib in the graph is mobilized the CLL cells out of the lymph nodes and other protective lymphoid niches. And for ibrutinib, accelerate the apoptotic cells killing by the sensitizing cells into the BCL inhibitors by venetoclax. So almost when they work together, the results will be best here. The Captivate was multi-center phase 2 evaluating first line, and the was showing 3 cycles of ibrutinib lead in 12 followed by 12 cycles of ibrutinib venetoclax. With after that, they post-randomized patients based on the undetected MRD, were randomized to 1:1 with placebo 43 patient and ibrutinib versus ibrutinib 43 patient. The undetected MRD were not confirmed, so they randomized ibrutinib, the first arm, the second arm, ibrutinib plus venetoclax. So here the subgroup analysis patient, unmutated patient, deletion 17, full baseline demographic and disease characteristics were reported previously. The median time for the 41 months after stopping treatment at 3 years, disease-free progression rate in placebo arm. This is post-randomization. There is no big, the complete remission were durable and with no significant difference duration in CR between the placebo and the ibrutinib group. For the at the 48 month, the progression-free survival were 88% with placebo and 98% with who continued ibrutinib, and or the same idea. The conclusion for the first line ibrutinib venetoclax as an oral and once daily chemotherapy-free regimen that continues to provide deep, durable responses in patient with CLL at 56 months median follow-up. Patient with an confirmed and detected MRD had 4 years PFS rate of more than 88% and 4 years overall survival rate with more than 90% across ibrutinib and placebo arm. Median 41 months after completing ibrutinib venetoclax, durability of undetected MRD and 3 years DFS rate was almost 85% in the placebo arm. So representing of fixed duration regimen further support the potential of durable management treatment free remission. The third study was almost the GLOW study. Was they put ibrutinib venetoclax versus chlorambucil and obinutuzumab, and the same idea, the same for regarding mobilizing cells. I will skip this one. It was 2-arm ibrutinib 420 and followed by ibrutinib venetoclax for 12 cycles and 6 cycles for chlorambucil obinutuzumab. This is the ibrutinib reduced the risk of progression-free survival or death by 79% versus chlorambucil obinutuzumab. The progression-free survival was better sustained with ibrutinib venetoclax versus chlorambucil obinutuzumab, regardless of MRD status at end of therapy for 3 years, and PFS was 3.5 years was higher in ibrutinib venetoclax versus chlorambucil obinutuzumab for both unmutated IGH and mutated IGH. More than 90% with ibrutinib venetoclax arm did not require subsequent treatment at 3 years, 3.5 years. So 91 in unmutated and 93 in mutated. So I will skip this one also. And the conclusion for the third study was 75% previously untreated older patient or combined patient with a life progression of 3.5 years with all oral once daily fixed duration ibrutinib venetoclax. It was fixed duration, novel combination to demonstrate overall survival advantage previously from untreated CLL. 2 years after end of therapy with ibrutinib venetoclax, nearly 40% of patients had undetected MRD less than 10 to the power 5. Estimated PFS more than 90% with patients with mutated IGH CLL, independent of MRD, regardless of or independent of MRD status. And for 60% of patients with unmutated IGH CLL who achieved detected MRD. Last study, FLAIR, I think they have the same ideas, but different stopping of the drug, either with international CLL or MRD negativity less than 0.01 or potential cure. The same here as inclusion previously untreated CLL required therapy, considered fit for FCR age of less than 75. 3 arms were FCR, ibrutinib, and maximum 6 years, and venetoclax with ibrutinib. Peripheral blood, as we mentioned before, every 6 months. If peripheral blood MRD negative, repeat after 3 months, and then peripheral blood and bone marrow at 6 months. If all MRD negative, then first peripheral bone MRD negative result is time of to MRD negativity. Duration therapy, double time to MRD negativity, minimum 2 years and maximum 2 years. This is current baseline for characteristic IGH involved and all the FISH result. I will rush for MRD. The result, significant result with ibrutinib versus ibrutinib venetoclax with significant p-value. And here the mutated, unmutated, the MRD negativity remission within 2 years, 79 in unmutated and 56 in mutated patients. MRD negative were 82% in deletion in Q11 deletion, and 70% in trisomy 12, 67 were normal, and 54 were in deletion Q13. The conclusion for the 42% patients stopped ibrutinib with venetoclax at 24 months of combination as per MRD stopping rules. Median time to MRD negativity in peripheral blood at 12 months, and median time to MRD negativity in bone marrow at 19 months. In conclusion, ibrutinib venetoclax resulted in 65% MRD negativity remission for bone marrow within 2 years post randomization. And 80% of with unmutated IGH and CLL achieved MRD negative remission within 2 years post randomization, compared with 56 for mutated IGH. 83% patient with deletion, 11 deletion, as we mentioned, MRD negative reached it with 2 years post randomization, compared with 54 with isolated Q13 deletion. And IGH unmutated more likely to achieve MRD negative in marrow and the blood with ibrutinib venetoclax. Ibrutinib venetoclax and ibrutinib were only well tolerated, and no new safety signals were seen. Now, I will just move on regarding the ASH presentation for 2021, and those how the previous studies was for ibrutinib regarding Resonate, Illuminate, ECOG 1912 superior PFS and OS versus FSAR younger patient, Alliance superior PFS versus PR in older patient, venetoclax CLL 14 was generating for the venetoclax obinutuzumab superior to chlorambucil and obinutuzumab, Murano venetoclax rituximab superior to BR. Sequoia also for zanubrutinib was supportive for superior of PFS versus PR. Alpine improved safety profile. Elevate for the naive treatment patient superior PFS for acalabrutinib regimen versus chlorambucil and obinutuzumab. Ascend study where have their inclusion improved PFS versus idelalisib, rituximab or PR. Non-inferior for the PFS versus ibrutinib and improved safety profile in Elevate study. So if I will go to safety profile, I will be very summarize in some studies. Here, the studies that have been still for the ibrutinib approved for the most of the CLL, mantle cell, marginal zone, and Waldenstone. Acala was approved for mantle cell and CLL. Zanubrutinib phase 3 approved in mantle and marginal zone and Waldenstone as well. Ibrutinib, the non-covalent BTKI group still under study phase 3 for CLL and MCL, nimtabrutinib as well. So this is what have been talking about the safety profile for the BTKI toxicity. As we know, AFib, arthralgia, infection, diarrhea, hypertension, bleeding, and additional side effect were dermatological changes, fatigue, cytopenia, and ventricular arrhythmias. Adverse event for the venetoclax, BCL inhibitors, tumor lysis, GI events, infection, and myelosuppression. How to deal with those? I will try to summarize them with summary for the safety. Don't give a concomitantly with warfarin for a new onset of AFib. Time of onset and repetitiveness of event are important. Consider non-warfarin anticoagulation and monitor for bleeding, particularly in young patients. Consider EP evaluation and ablation study. Hypertension, manage antihypertensive and change to second generation of BTKI can help as well. Arthralgia, you need to rule out other causes and monitor the use of supportive care for lower grade events. Magnesium, calcium supplements sometimes will help. Dose reduced or consider second generation BTKI once symptoms affect the adverse. If high grade arthralgia, develop hold and consider second generation. For the question of the headache, commonly in acalabrutinib, after it resolved within 1 to 2 months, managed with acetaminophen caffeine. If this occurs or unbearable, often try to give single daily dose at night and then titrate BID in the following month. Neutropenia, particularly with zanubrutinib, for neutropenia, first occurrence dose interruption is recommended once toxicity has resolved to grade 1 or lower. Baseline, resume it to 160 BID, then or 320 daily. So as we know, ibrutinib is less selective and has more. As we see, ibrutinib less selective, more of target effects. Bertobrutinib on the other side, more selective and less target effect. The more selectivity, less side effect. I will finish. Last slide for the side effect regarding the acalabrutinib. Burden lower with acalabrutinib, lower risk factors and side effect for the AF flutter, hypertension, hemorrhage, musculoskeletal, and more with diarrhea and headache. This is the, I think we need to, before we started the ibrutinib or BTKIs, we need to screen patients for cerebrovascular disease risk, echocardiogram, and cardiac biomarkers, CVT, FRS, CVT score, certification. Always patient without cardiovascular risk, we can pick up any BTKI if other safety concern for more selective drugs, acalabrutinib, zanubrutinib, or BCL2 inhibitors. Patient with cardiovascular risk, well-controlled AFib, hypertension, heart failure, or valvular heart disease. Consider second generation or BTKIs like acala or zanubrutinib. This is very important. I cannot skip this one. It's very important how to deal with these doses. When I have ibrutinib with strong CYP3A inhibitors, I need to reduce the dose to 140 for short time, less than 7 days, interrupting the dose. For moderate inhibitors, I will continue with 280. Try to avoid it with the strong inducers, and no need for dose adjustment in PPI. Acala was you should to avoid it with strong inhibitors. Moderate, you can reduce the dose to 100, and should be avoided if necessary with strong inducers. Increases to 200 should be avoided with PPI inhibitors. Acala with immediate release also as well the same, but can be used with PPI inhibitors. Zanubrutinib, reduce the dose with strong inhibitors to 80 milligram, and for moderate, use it twice daily. Should be used with should be avoided with strong inducers and with no dose adjustment with PPI. Regarding the last point, I need for the BTKI inhibitors toxicity and inhibitors, and how well I will evaluate patients who were having disease progression on covalent BTKI is often accompanied by resistant mutations, and most of those mutations was C481S conferred resistant to all covalent BTKI. So this is how we use how those resistant to intolerant limit outcome with covalent BTKI inhibitors in CLL, 56% with BTK mutants, and for phospholipid CG2 mutant were 80%. Both mutation were around 16%, and mutation was not detected for about 20%. So regarding the this is how we use the covalent bound C418. Pirtobrutinib does not require C480 to bind it with the kinase domain. So I think the bone update, this is for the patient who have also resistant. There are many studies, Bill, where also they mention about the resistant and CLL. This is a brief of these mutations: L528, V416, M437, T474, and A28. So this is the most recent discovered mutations for BTKI who was discovered. This study was still under progress, and for the drug which is non-covalent and it is for the BTK mutation resistant to covalent and non-covalent BTKI with BCL2 mutations. And this is, I think I reached to the last home messages, and I skipped many. BTKI intolerance does not exclude this class of drug, can be managed by switching to a different covalent BTKI. BTKI resistant requires to change to a different type of BTKI class of drug, with venetoclax being most proven. Patients with BTKI resistant require a long-term strategy that should include investigation therapies, non-covalent BTKI, or cellular therapies. Thank you very much for rushing. I appreciate it.
Thank you so much, Dr. Anas, for this very comprehensive and nice presentation. And this tell me that there are a lot of data need to be digested for novel therapies for CLL treatment. So now the time for the question and discussions. I will ask the three speakers to be available for answering questions. So Dr. Anas, Dr. Muhammad, and Dr. Firas is available with us online. So I will start asking Dr. Firas if he is with us now. Dr. Firas? Huh? So Dr. Firas apologize, he's not around. And but I still ask the question about AML to the other speakers. Regarding AML management, Dr. Firas nicely presented his data about, so Dr. Firas is not here, so I can say elderly freely, no problem. So for elderly patients who are fit, for therapy, the guidelines recommendation all mention that patients should, and so, but let's keep the data away. I'm talking about experience. Many hematologists now change the treatment to azathioprine instead of intensive chemotherapy for fit old patient, and the aim is to just induce remission. Then further therapy could be like consolidation with chemo or allotransplant. So from experience point of view, not from the data, what do you think, both speaker, about changing therapy for a fit patient? Dr. Muhammad, Dr. Anas.
Will answer on behalf of Dr. Firas. This is my view. I think from our experience in King Fahd Medical City, we have been using azathioprine more frequently now, even in young patient. We have reported as an abstract in ASH, I think a few years ago, like 2 years ago, I think 2021, where we do have even young patient refractory to conventional chemotherapy, including 7+3. One of the patients also, one of the patient, I think, has very complex karyotype and cytogenetic, was very successful to achieve remission with azathioprine. So we need more data on that, more phase 3 clinical trial, head-to-head study in young patients. But we have reported as a second line, I would say, azathioprine in young patient with very good response rate.
Dr. Anas.
Actually, the practice usually is more in small centers regarding those elderly, because the one who is receiving the upfront is the small centers that they are dealing with. And if you decide from beginning that you will by your assessment risk stratification, all the modalities that have been mentioned by Dr. Freire. So it's going to be much easier if you have all the cytogenetic for the patient and you assess for him. But sometimes you have some difficulties, logistic. You cannot risk assess the patient. So you need to have a very fine way, very nice way to deliver the chemotherapy. But because of fewer patients, sometimes they ask to be transferred. Some ask, but sometimes the eligibility in higher centers cannot be accessed for them. So we always try to either find, maybe it's all generation 2+5, but try to reach your patient in remission. Then, as you mentioned, consolidation will be light chemo, or even something is based on your experience with this patient with the first induction. If he underwent an ICU, if he become comorbid more, so you will try to decrease give him light chemo, at least like palliative chemo, almost, yani. But there is really no, we don't have a standard. We don't have a lot of cases that we manage case by case. Yeah, this is most of them.
So other questions regarding CLL presentation, hemophilia presentation? So from the audience. Yeah.
Again, for AML, how you will overcome the effect of or side effect of venetoclax and either for elderly patients. Usually have very difficult in our patients. Most of them they want cytopenia immediately, and we cannot give the proper dose for them.
Yeah, this is a good question.
Very good question.
Yeah, so we have a plastic anemia patient. So we convert them from AML to a plastic anemia. So go ahead, Dr. Mohammed.
Yeah, so the protocol is 28 days venetoclax with azaven in combination. So we found that elderly patients, they don't tolerate such period, and the dose as well, like the maximum dose. So what we usually do is, if we achieve remission after one cycle, you could do 14 days of venetoclax. Or even I have a patient only 1 week of venetoclax with azaven, with azacitidine. There was an abstract in last ASH, 7+7. I mean, as a cytidine plus 7 days of venetoclax, just to reduce the risk of cytopenia and the complication later on. Yeah, I mean, we have two patients, elderly patients, as Dr. Martibi mentioned, said. They developed a plastic anemia after 2 cycles of azaven, bone marrow completely empty. So it's a big concern. I mean, it's go by case, but you could reduce the period of venetoclax if the patient achieve remission.
Yeah, we do dose interruption, and we use the minimum tolerated I don't know, minimum or maximum tolerated dose, whatever. Correct. So I have even patient on 100 milligram, and they are doing well. So the time is running out. We have to move to the next session, but I have a small question with short answer from Dr. Anas. Now, with CLL management, a protein and venetoclax combination is very financially toxic, very expensive, but it seems to be cost effective if it will lead to cure. So
Yes.
are we talking about cure now in CLL with these approaches?
Up to 6 years based on this MRD negative studies. And I think less invasive, less side effect, especially. But when you go deep through with these drugs, you find about side effect is increasing with more after 1 to 2 years using of ibrutinib. And sometimes you might have a mutation resistant. But you have an alternative. You did not use the obinutuzumab, still you did not use the venetoclax. So, but the best is ibrutinib right now and venetoclax for the upfront, without deletion 17. So with high risk or low risk, the same.
So thank you, Dr. Anas, and thank you to Dr. Muhammad also. Thank you, Dr. Firas. And this time now to move to the next session with Dr. Jadallah. Thank you.
So the next session will be with Dr. Ayman Mehshi about interpretation of hemoglobin electrophoresis. Dr. Ayman, he's a consultant hematopathologist in King Fahd Central Hospital, and he's one of the senior hematopathologists in the region, head department of hematology lab in King Fahd. So floor for yours is Dr. Ayman.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. We go about يعني clinical side to more laboratory side. I will talk about hemoglobinopathy interpretation, hemoglobin electrophoresis interpretation in hemoglobinopathy cases. For understanding the hemoglobinopathy, we need to understand hemoglobin molecules. Each hemoglobin molecule contain 4 change protein, 2 alpha, 2 beta in the normal hemoglobin, and is carrying the heme groups which combine to be hemoglobin. This figures is very illustrated from Hofbrand, containing a lot of information for understanding the hemoglobin synthesis and hemoglobinopathy's pathophysiology. To need to understand the production of hemoglobin, starting by the type of cells, site of the erythropoiesis, and the globin synthesis. As you see, the globin synthesis is starting from before 6 weeks in the embryo, and the alpha change is starting to switching up with the zeta change to be the leading of the hemoglobin, the globin synthesis. I can say no alpha, no life for a baby. Then there is another part of we can use the mouse. Hold in the so the first one. Can use the mouse here. Will not appear. Okay. I will go back. Sorry for that. As you see, starting to the birth with 30 weeks, starting the switching of the gamma change production to the beta change production, which are producing the normal hemoglobin in the postnatal age. In the chromosome 16, we have alpha change, the major change for production of hemoglobin. In the chromosome 11, we have a beta and epsilon and delta and gamma change. In the fetus, within embryo period, we have GAWR1, Portland, then GAWR2. In the fetus, we have hemoglobin F with containing 2 alpha, 2 gamma, and hemoglobin A starting to be production by hemoglobin alpha 2, beta 2. And the A2 also is starting production by alpha 2, delta 2. This is the normal hemoglobin, hemoglobin A. At the birth, we see the 20 to 25% of the total hemoglobin, and level of the 97 by age of 1 year, completely switching of production. Then an A2 start by 0.5 to the B, 2.5, the normal in the age of 1. Also, hemoglobin F should be by age of 1 or 2 years, maximum to be less than 1. And the hemoglobin H and hemoglobin bar should be, hemoglobin bar should be missing in this, in the age of 1 year. For diagnosis of the hemoglobin electrophoresis, we need a clinical and hematological parameters, and also hemoglobin analysis. This is important for treatment, prevention, counseling, and prevention and awareness of the crisis, especially in the sickling disease. For testing protocol, we need a good clinical evaluation for anemia, what clinical symptoms, and also there is a clinical splenomegaly, hepatomegaly, or other clinical information will help us to reach the diagnosis. Then in our lab, we do CBC, reticulocyte count, and peripheral blood smear in some cases, electrophoresis by this is the old method, cellulose acetate and citrate agar. Also, isoelectric focusing can be used in some centers, HPLC and capillaries or advanced molecular. This is more illustrated diagram. We need to go some time to be using a mass spectrometry or also the DNA analysis to reach the diagnosis. Also, the other part we need to, in the thalassemia or other microcytic hypochromic anemia, we need to do ferritin and serum iron investigations. The more important clinical information, we need a name to be exact, handling with the same patient, date of birth to know the age of patient, hospital number, and ethnic origin or regions. Before maybe 1 month, one patient has come to me to show me the electrophoresis, and the electrophoresis is not doing in the private hospital, and the patient have for pre-marriage have abnormal hemoglobin, not common in our areas, and when repeat in our lab, there is a normal electrophoresis is missing with one of the non-Saudi persons. So we need to know ethnicity and reason of testing, clinical information, pregnancy testing for status, and recent blood transfusion. This is one of the missing information. Usually we face it in our lab, in other lab, no history of recent blood transfusion because it's affecting the result. Relevant drug therapy, iron and hydroxyurea, especially in the sickle cell anemia, also partner screening, we need it in some cases. This is normal CBC. We need every parameter, microcytic hypochromic or normocytic normochromic anemia, reticulocyte, nucleated red blood cells, and also blood film. Clinical importance in hemoglobinopathy mutation for sickling disease or thalassaemic disease, structural disease, decreased solubility, unstable hemoglobin, abnormal hemoglobin, oxygen affinity mutations. We need to look for this mutations. In our lab for hemoglobinopathies for electrophoresis, there is a common method, quickly densitometry by alkaline acetylose acetate electrophoresis, acid citrate agar gel electrophoresis, HPLC, sickling screening test, solubility test. In some cases, we need to go to make a supraphytal staining for hemoglobin H and capillary system, capillary electrophoresis. This is the densitometry as an old method, and in the left side there is acid electrophoresis, usually starting by alkaline. In the right side, which are the hemoglobin starting to migrate from cathode to anode, and the fast moving is hemoglobin H, and usually, as you said, the hemoglobin S is interfere with other hemoglobin in this gel. For acid, there is more differentiation in hemoglobin S. As you see, the hemoglobin S is be more easier to confirm the hemoglobin S carryover. This is the machine of high performance liquid chromatography. HPLC is using in the worldwide and also Federation of Thalassemia International Federation is recommended for a screening method. This is usually depend on the typical retention time, and is measuring hemoglobin F and measuring hemoglobin A2, and there is a window for hemoglobin S and C and D, and the hemoglobin A will be calculated in this method. This is the photogram or chromatography is appearing. This is the normal cases, and this in the C, there's high hemoglobin F and S in this case. Second solubility testing, usually this is the old method, you know it, everyone is we read the line, this is negative. If there is a turbidity, cannot read the line, this is a positive cases. Hemoglobin H inclusion bodies is golf ball appearance in the supraphytal staining, and should be differentiated between retic and hemoglobin H. Capillary system was more advanced technologies in the electrophoresis, and this is the machine, and we'll go to this illustrated diagrams showing the when from starting and the hemolysis is happen, and dilution, injection, and also the same starting from anode to the cathode, and quantitative after that will done in the lab. This is the zone by the appearance is starting by zone. Let's see, the zone 5 is containing hemoglobin S, which contributed in the hemoglobin Hashron only. This is the common, the control we usually using in the lab, mixing of the hemoglobin A, F, and S, and A2 and C. And this is the normal hemoglobin pattern is coming from the machines, is as you said, so here the hemoglobin A containing 97%, and hemoglobin A2 is 2.6. This is in alpha thalassemia with hemoglobin H. You see the zone 15. There is a fast moving hemoglobin. And in this cases, you see there is a no hemoglobin A, and the containing of high percentage of hemoglobin S is 81%. This is a homozygous SS sickle cell anemia. For this is complicated, but usually screening of anemia starting from microcytic hypochromic. If have a low MCV, normal MCV, or high MCV, we need to do to look for other parameter of the CBC indices, and then after that we can do the peripheral blood smear and other investigation like iron study, electrophoresis, hemoglobin electrophoresis, or other cases in the normal MCV, we go to the comb test or osmotic fragility enzyme assay for G6PD. In some cases, in the high MCV, we need to go sometime for a bone marrow investigations for anemia. This is the normal A2 levels, usually is not exceeding 7. If exceeding 7 A2, this is another hemoglobin, or there is something abnormal in the machine. The cases of the 3.8 to the 7, this is a beta thalassemia trait, and no doubt about it, or other unstable hemoglobin. But the difficulty of us usually in the cases having hemoglobin A2 level from 3.4 to 3.7, which are so difficult to judge about this is a thalassemia or not thalassemia. And usually in these cases, it is the cases of going to the sometime for a DNA study. For hemoglobin F levels, usually is by age of 1 year or 2 years maximum, should be less than 1. But if it's still persistence less than 5, we look for some abnormality and also sporadic in some generation. In some generations is seeing is little increase. For hemoglobinopathy is autosomal, most like majority of them are autosomal recessive. Inheritance is qualitative, hemoglobin variant, sickle cells or other. Quantitative is in production. This is a thalassemia cases. This is the major hemoglobinopathy, thalassemia, type of all thalassemia, alpha, beta, gamma, delta, beta, or epsilon, gamma, delta, beta thalassemia. Other type is hereditary persistence fetal hemoglobin, so pancellular or heterocellular. Thalassemic hemoglobin variant is alpha or beta variant, and abnormal hemoglobin variant, alpha change variant, beta change variant, which is common is in the sickle cell anemia in our area, and delta or gamma change variant. This is the other the study from the US showing the majority is around 55% of the hemoglobinopathy disease are clinically silent, and around 29 of them are abnormal oxygen transportation function, low affinity or high affinity, 26% unstable hemoglobin, and reducing hemoglobin sensitivity like thalassaemic phenotype, only 5%, and sickling is only 1%, and methemoglobin is 1%. But this study is figuring that our kingdom, we need to do more research or more study to figuring the exact percentage of our country for hemoglobinopathy status. This is from Witherall, which are one of the famous professor in the hemoglobinopathy, and especially thalassemia. And you said there is around 270,000 birth yearly of the sickle cell disease and worldwide, and this is a huge number, and we need to look about newborn screening or other method to catch it earlier and managing the cases. This is the known figure is known as thalassemia belt. See this starting from African to the Far East. This is the thalassemia syndrome. There is some clinical asymptomatic syndrome, which are usually missing and not under investigated. There is thalassemia intermediate, who can be sporadic cases from the asymptomatic to the sometime to be transfusion dependent. And also the last part is thalassemia major, is the transfusion dependent, which are seeing daily in the daycare or in the hospital in this area. This is also figure to how to investigate the thalassemia. If there is a normal MCF general is no investigation in our country, and you need to look for this area because there is some cases with normal MCF can be thalassemic. Usually is low MCF, low MCH. We're starting to, if there is low hemoglobin, this is to do further investigation. If the normal hemoglobin needs to be normal, we need to go A2 levels and to classify the thalassemia. As you said here, there is a lot of the thalassemia can be missing when the hemoglobin A2 is less than 3.6, which are clinically silent thalassemia. What is important to look in the cases of the pre-Mariter and testing to look at this area which is missing. This is the publication of the thalassemia mutations in our kingdom. We look for the past mutation detected in our kingdom. We have a 19 mutation of the beta thalassemia mutation causing the beta thalassemia major. And of them, there is a 5 major and matching in with like a fingerprint or 5 major mutation in thalassemia in our kingdom. We need to look about it. You know, this is the exact how happened the variant of hemoglobin. Usually substitution happen between in the some area of the beta change, and there is filling coming instead of the glutamic acid in the position 6 of the beta change, and this making the sickle cell disease. And this is the separation of sickle cell disease worldwide. Genotype. This is how to investigate, or schema illustrating how to investigate the cases of sickle cell anemia. This is matching the thalassemia and sickle cell investigation. After CBC, we need to look for hemoglobin electrophoresis, and if normal, this is normal. If more than 3.5, this is by default, this is a beta thalassemia until proven otherwise. If less than 3.5, we need to do another investigation, iron or zinc probanol or other investigation to detect it. In the cases also less than 5 and quantitative of the F is not clear, we need to do DNA analysis for these cases. This is the genotype of the sickle cell anemia, sickle cell SS, which are 2 allele, more severe disease, and is more common in our regions. The other is beta naught, which are less here in our regions, which are almost sickle cell disease by clinical manifestation. Sickle cell with D usually is I think no have cases, Dr. Hafid, maybe here in our regions. With beta plus, we have some cases of beta plus, which are usually present with some amount of hemoglobin A in the electrophoresis. We go further to the this or we'll go back for this of the one of the more easier for interpretation of the result of the electrophoresis in the patient with sickle or beta thalassemia. In adult, if there is normal MCV, MCH, and hemoglobin S between 35 to 38, and there is hemoglobin A and A2 less than 3.5 and F less than 1, this is most likely is sickle cell trait. If the MCV also normal and the S is more than 80 and the A is absence and hemoglobin A2 less than 5, 3.5, and some cases is a little bit high, especially in the hemoglobin HbA1c. This case is usually with thalassemia, with the sickle cell disease. If there is a low MCV, MCH, and S is the high, but no A, but A2 is more than 3.5, should be looked for a beta thalassemia combination with S, beta not thalassemia. We need to do clinical interpretation and investigation for a father and mother of this patient if it's alive. And if less, also MCV and MCH and S is less than 93, but there is a hemoglobin A And if between 1 to 10, we need to look about the sickle cell with beta thalassemia. If MCF is normal and there is a high hemoglobin F with a high hemoglobin S, so in absence of the hemoglobin A, we need to look for sickle with the hereditary persistent fetal hemoglobin. But in this case, be careful. We need to see if the patient on the hydroxyurea or not, because the hydroxyurea will be elevated the hemoglobin F and masking the interpretations. If there is a low or normal MCF with a high A and less S, then less than 35, we need to think about the hemoglobin S with the alpha thalassemia plus. If there is a low MCF, clear low MCF, and the hemoglobin S is less than 30, this is usually with beta, hemoglobin S with alpha not or alpha 0 thalassemia. If in the cases of normal or low MCF and only S and the hemoglobin F between 1 and 10 and the less A2 is so difficult to interpretation if this is a sickle cell anemia with alpha thalassemia, because no A and the MCF is normal will be difficult and need to do lab molecular or DNA investigations. Okay. For that, this is showing how the clinical interpretations also in the MCF and hemoglobin, but I will for sickle cell screening, we need newborn screening. For thalassemia, we need newborn screening, and yesterday we hear good news from Dr. Hatoun, because starting already newborn screening as a pilot study in the Al-Ahsa region and through the Wiqaya, and inshallah will be the other area will be coming in soon in the program. We'll escape all the clinical, but we knew interpretation the results and for premarital, and which the best combination of the sickle cell disease with which hemoglobinopathies. Alpha thalassemia, other, hemoglobin E. Hemoglobin E usually asymptomatic, and if we go back, see hemoglobin E, the third from down is usually hemoglobin, main hemoglobin 13s, normal, picture, no crisis, usually within the combination with hemoglobin S. But this is one of the affecting of the hemoglobin E is the prevention the hemoglobin S polymerization, and is best combination also with the in this cases with the sickle cell disease. I will conclude. This is the articles is coming from Dr. Said, and for detection of the hemoglobinopathy disease in the Saudi Arabia for premarital testing, and this is the key of how to make a planning, a screening program in the kingdom or in other areas. And you as see there is a huge number of the cases in our region, Jazan, and also Al-Ahsa and Eastern regions. Thank you.
Thank you, Dr. Ayman, for excellent talk. The next session will be with Dr. Fahad Bahkali about beta thalassemia treatment approach. Dr. Fahad, he is a consultant adult hematology in British Mohammed bin Nasser Hospital, currently in King Faisal Specialized Hospital, Riyadh, bone marrow transplantation program. So, floor is yours, Dr. Fahad.
Assalamu alaikum jami'an. Actually, I'm happy to be with you today and to give me the chance to present in front of all of you, especially my senior colleagues and my teacher, Dr. Saud Al-Haili. Today, inshallah, I will present to you about the beta thalassemia treatment approach. Again, this. So, introduction to beta thalassemia. Beta thalassemia is a common genetic disease, and it's a quantitative globin gene disease where there is a decreased rate of synthesis of one or more structurally normal globin chains due to deletion or mutation, which lead to unbalanced chain synthesis with excess of normal globin chain and lead to ineffective erythropoiesis and hemolytic anemia, which I will explain it in details in the coming few slides. The body usually tries to compensate this by increasing the rate of hematopoiesis, and sometimes this will happen at an extramedullary sites, leading to more and more complications. As you can see in the left side of the slide, we have two types of beta thalassemia, which is beta zero thalassemia, where you have no production of beta globin chain, and you have beta plus thalassemia, where you have a decrease in the production of beta globin chain. In the right side, actually, it's the pathophysiology of the disease. You have, as we said, beta zero thalassemia and beta plus thalassemia leading to excess of alpha chain, and this will precipitate in the RBCs, leading to ineffective erythropoiesis and hemolysis, and as the sequence will lead to anemia. For the anemia, we are giving the patient blood transfusion, and this will lead to iron overload and its known complications. And the body usually will try to compensate for anemia by two mechanisms, which is increase iron absorption through the intestine, and this will lead to more iron overload and complications, and also trying to compensate by extramedullary hematopoiesis, leading to bone marrow expansion and skeletal changes and abnormalities. This is basically the new classification of thalassemia based on Thalassemia International Federation. They classify the patient as transfusion-dependent thalassemia and non-transfusion-dependent thalassemia based on clinical evaluation, including clinical symptoms of anemia, severity of anemia, signs of extramedullary hematopoiesis, and transfusion need. For the transfusion-dependent thalassemia, the two common types is beta thalassemia major and severe hemoglobin E beta thalassemia. This is actually the typical finding of hemoglobin electrophoresis in a normal population and in a patient with beta thalassemia. As you can see in the right side is the finding of hemoglobin electrophoresis in patient with beta thalassemia major in a non-transfused patient. The majority of their hemoglobin is hemoglobin F, and they have a variable level of hemoglobin A2, and they don't have any amount of hemoglobin A. Starting with beta thalassemia minor. Beta thalassemia minor, usually they have a microcytic hypochromic anemia with a hemoglobin level ranging from 9 to a normal level. And based on the hemoglobin electrophoresis, they will have an elevated hemoglobin A2 more than 3.5% usually. Those patients are asymptomatic patients and they don't need any management. However, it's very important to identify those patients because of two things. The first thing, to avoid unnecessary iron supplementations, because those patients usually misdiagnosed as iron deficiency anemia. The second reason behind that is to provide them with enough education and genetic counseling. transfusion-dependent thalassemia. Patients with transfusion-dependent thalassemia, usually they will die before the age of 5 if we did not give them a blood transfusion. The two important transfusion-dependent thalassemia is beta thalassemia major and severe hemoglobin E beta thalassemia. They have an extramedullary hematopoiesis, and this extramedullary hematopoiesis, if happen in the skull, it might cause convulsion, and if it happen in the spine, it might cause spinal cord compression. And the typical hemoglobin electrophoresis, as we mentioned in the previous slide. Non-transfusion dependent thalassemia basically is something in between. Those patients, they have a moderate anemia, moderate level of hemoglobin. They need blood transfusion on and off, especially at the time of illness, infection, and fever and pregnancy. And they have some complications, maybe like patient with transfusion dependent thalassemia, but less severe and less common. Coming to the approach to the beta thalassemia. Coming to the approach to the beta thalassemia, this is actually a very interesting slide. You know, in 2003, the Saudi government, they decided to implement the mandatory premarital screening, aiming to decrease the most common hemoglobinopathies in the kingdom, which is sickle cell and thalassemia. From 2003 and to 2005, they did a screening for almost 500,000 individuals, and they identified 2,375 high-risk couples for having an offspring with hemoglobinopathies. Then they contacted them by the phone a few months later after giving them enough education and genetic counseling, and they found that 90% of them, they married each other, despite they know that they are at high risk to have an offspring with hemoglobinopathies. So the conclusion of that, this premarital screening actually at that time, in 2005, was successful to screen a vast majority of eligible patients and to identify couples at high risk of having an offspring with hemoglobinopathies and to provide them with enough genetic counseling and education, but was not successful to achieve the main goal of decreasing the incidence of this disease in future generation by eliminating or significantly decreasing the number of high-risk marriages. We believe that the outcome for thalassemia patient is much better if delivered at a specialized thalassemia center. This is actually interested. It's a registry study from Italy. They included 50 patients, 41 patients of them treated at a specialized thalassemia center. They are still alive at age of 30, where the 9 patients treated at a non-specialized thalassemia center, they died at age of 23. So this is emphasizing that those patients should be handled and managed in a specialized thalassemia center where you have good equipment, lab and hematology and all specialty available. As we know, before 1960s, thalassemia major patient used to die early in the life, in infancy. In 1960, they invent the chronic transfusion, and then the patient, they live till second decade of life, and then they died because of complication, including iron overload. In 1970s, they started iron chelation therapy, and the disease became more and more chronic disease. And in 1980s, they started hematopoietic stem cell transplant. As you can see in the right side, the survival is increasing with the advent of blood transfusion and iron chelation and hematopoietic stem cell transplant. For the blood transfusion, the aim is to reduce the symptoms and comorbidities associated with anemia and to suppress the extramedullary hematopoiesis. The target blood transfusion is a hemoglobin level pre-transfusion of 9 to 10, and this will usually relieve the symptoms of anemia and suppress extramedullary hematopoiesis and minimize the transfusional iron overload. The decision to start long-term transfusion depends on many factors, and long-term transfusion is not without complications. We have many complications related to that, including hepatitis, transfusion reaction, alloimmunization, and iron overload. In the bottom of the slide, you can see that matching for ABO, DCE, and KIL is preferred in thalassaemic patient. Thanks God, thalassaemic patient, they have a less risk of developing delayed hemolytic transfusion reaction and aluminization compared to sickle cell anemia. And most of their antibodies are against RH and KIL. There is some factors associated with high risk of developing aluminization, including older age at the starting of blood transfusion and the splenectomy. The mechanism behind that is unknown. Iron overload, it's a major complication in transfusion-dependent thalassemia and non-transfusion-dependent thalassemia. As you know, each 1 ml of blood transfused contain 1 milligram of iron, and transfusion is not the only mechanism of iron overload in thalassemia. Usually thalassaemic patient, their body try to compensate for the level of anemia by increasing the iron absorption through the intestine. So 2 mechanisms leading to iron overload in thalassemia, which is transfusion and increased iron absorption through the intestine, which is a normal mechanism by the body. This excess iron, it will accumulate in the organs and leading to dysfunction. And interventions to mitigate these major complications include pre-transfusion hemoglobin not more than 9.5 to 10.5, which is usually sufficient to elevate the symptoms of anemia and suppress extramedullary hematopoiesis. We need also to monitor those patients for iron stores in the body using ferritin level and some images. And we need also to initiate iron chelation therapy early in the course of the disease. The methods to monitor the iron overload, including ferritin level, although we know it's an acute phase reactant, but we can use it every 3 months. We need to do liver iron concentration by MRI starting at age of 5 in transfusion-dependent thalassemia and need to be done annually. Cardiac iron overload is starting at using MRI starting at age of 8 to 10 in transfusion-dependent thalassemia and need to be done also on an annual basis. When to start iron chelation therapy in thalassemia, especially in transfusion-dependent thalassemia, we have different approach by different clinicians and different guidelines. Some of them, they will start when the ferritin level more than 300. Some of them, they will start when at the time of starting long transfusion. And some, they use the cut limit of ferritin level more than 1,000. And some of them, they will just rely on the image. If they have evidence of cardiac iron overload or liver iron overload, they will start the iron chelation therapy. The goal is to achieve a ferritin level less than 1,000 and liver iron concentration of less than 5 mg and a cardiac T2 more than 20 milliseconds. As we said, iron overload can accumulate in any part of the body, most importantly in the cardiac iron overload. Why is that? Because cardiovascular complication is the main reason of death in transfusion-dependent thalassemia. We need to do an annual ECG and echo. It's recommended in all transfusion-dependent thalassemia starting at age of 10. And what we noticed is that complete normalization of cardiac function and reversal of left ventricular dysfunction have been observed in transfusion-dependent thalassemia with good adherence to chelation therapy. We have 3 main types of iron chelation therapy available. We have tablets like XJADE and Jadinio. And we have also deferebron, which is 3 times daily with a risk of neutropenia. And it showed some benefit in myocardial iron overload. And we have deferoxamine, which is subcut and IV to be infused over 8 to 12 hours per day for at least 5 days per week. And as you can see in the lower part of this slide, longer infusion of deferoxamine over 24 hours showed some benefit in high-risk thalassemia, like patients with cardiac iron overload. This is like a table to summarize what we have said about the iron chelation therapies, dosing, major side effects, and follow-up. Treatment of long-term complications, as we said, thalassemia, they have major complications, but I will talk mainly about the endocrinopathy. Transfusion-dependent thalassemia patients, they need to be seen by endocrinologists on a regular follow-up, they have a chance of hypogonadotropic hypogonadism of up to 90%, 50 to 90%, and they have a chance of diabetes 20 to 30% and hypothyroidism up to 10%. And they might have some bone complications, including osteopenia and osteoporosis, and they need regular follow-up and calcium and vitamin D and physical activity. This is other long-term complications for transfusion-dependent and non-transfusion-dependent thalassemia, which include, as we said, heart failure, arrhythmia, hepatitis, delayed puberty, diabetes, glucose intolerance, extramedullary masses, thrombosis, pulmonary hypertension, and leg ulcers. A splenectomy, it's not actually without complications. It has many complications, including surgical complications, infection, pulmonary hypertension, and thrombosis. We have to consider it in a case by case, especially in those patients with hypersplenism, like causing pancytopenia or symptomatic spleen. The usual first line approach to patients with splenomegaly is by increasing the transfusion, which may decrease the size of spleen sometimes. If the decision of a splenectomy made, then the patient needs to be vaccinated and has to receive antibiotic for at least 1 year post-op. This is one point, maybe it will be addressed in the coming session, about the luspatercept in a splenectomized patient may increase the risk of thrombosis sometimes. Finally, I will come to the few slides about hematopoietic stem cell transplant. As we know, hematopoietic stem cell transplant can be curative for thalassemia in a good percentage of patients when we select a good candidate for that. Actually, when performed in the childhood, it has more than 90% chance of success and less than 4% risk of transplant-related mortality. We know it's an expensive procedure, but less than gene therapy. It has many complications. The best candidate is a child with transfusion-dependent thalassemia who has a matched sibling donor with a good performance status and normal organ function with acceptable ferritin level. Basically, there is no randomized trial comparing continuing medical therapy, which is blood transfusion and iron chelation, versus hematopoietic stem cell transplant. The factors associated with good outcome include young age at the time of stem cell transplant and using bone marrow stem cells as a source of stem cells. In the last ABMT, they identified the age of 14 as the oldest age of optimal outcome in matched family donor hematopoietic stem cell transplant. However, still transplant can be done even if the patient is more than 14 years old. As we said, and as we know, the concept of hematopoietic stem cell transplant in non-malignant disease is totally different than malignant disease. In non-malignant disease like thalassemia, there is no GVL effect, so we don't accept any type of GVHD. Again, that's why we should select our patient carefully with a good assessment of iron contents in the liver and in the heart, and to select the most suitable patient, the good candidate to achieve the best outcome. Selecting the best candidate is very important, and conditioning should be adjusted based on the organ function and comorbidities, because we know that those patients, they have some limits, some types of organ dysfunction at the time of transplant due to iron overload. Defibrotide has been used successfully to prevent SOS/VOD in patients with transfusion-dependent thalassemia undergoing hematopoietic stem cell transplant with conditioning containing IV busulfan. As you see in the right side, this is the outcome of hematopoietic stem cell transplant in thalassemia from the EBMT from 2000 to 2010. The first one is the age less than 14. You can see the outcome is excellent with a 2 years overall survival of 90 to 96% and 2 years thalassemia-free survival of 83 to 93%. Just for the age more than 14, the outcome is less, where the 2 years overall survival of 80 to 82% and 2 years thalassemia-free survival of 74 to 76%. And the result is much better if you use the matched sibling donor. So if you use the matched sibling donor and you did the transplant early before the age of 14, the outcome is much better. We came to the conclusion, beta thalassemia has different phenotype and different presentations. The premarital screening is important to provide enough education and genetic counseling. The mainstay of management is blood transfusion and iron chelation therapy. Monitoring of long-term complications related to blood transfusion therapy is very important. A splenectomy can be considered, especially if pancytopenia and the size of spleen did not decrease with transfusion. Evaluation for hematopoietic stem cell transplant should be considered in fit patients with good organ function, preferred to be done at young age before the organ dysfunction developed. New modality of management are promising, including gene therapy, luspatercept, and other investigational therapies. And thank you so much.
Thank you, Dr. Fahad, for excellent talk. I will ask Dr. Ayman Mehsha and Dr. Fahad to answer some question of the attendee and audience. Dr. Ayman Mehsha is here. My question to Dr. Ayman, you talk about hemoglobin electrophoresis, which was diagnostic in hemoglobinopathies. And as you know, here in our region, the most areas that they have prevalence of sickle cell disease. And the availability of hemoglobin electrophoresis only here in King Fahad or regional lab. So my question, how sensitivity of sickling test in peripheral or local hospital, sometimes patients who are not diagnosed and they come with complication, patient severely ill in ER, and only from the history they said that he has sickle cell anemia, and asking for hematologist to take care of the patient despite that he has no evidence. So they are doing sickling test in peripheral hospital and calling us. How sensitive is sickling test before confirming by hemoglobin electrophoresis?
Hemoglobin electrophoresis is available. HPLC is available in many hospitals here. Yani, it's not only King Fahad or regional lab. King Prince Mohammed have it, Santa Hospital, Sabia Hospital, Beish Hospital. Yani, more than 7 or 8 hospitals having the hemoglobin electrophoresis machines. Yani. Sickling solubility test cannot differentiating sickle cell disease from sickle cell trait. But the clinical situation of a patient crisis or can help to help the clinical physician to decide this is sickle cell trait or sickle cell disease or sickle cell trait having another clinical scenario. But depend on clinical scenario. So usually sickle cell trait is not having hemolysis, not have crisis, can be but 100% to be differentiated in between sickle cell disease or sickle cell trait, we need hemoglobin electrophoresis. Sickle solubility test can be abnormal also in other hemoglobin like unstable hemoglobins.
Okay, thank you. Question from the audience. تفضل دكتور حافظ.
Assalamu alaikum. Thank you so much. Very excellent presentations. I have one question for each. So I'll start with Dr. Ayman. So regarding the characterization of sickle cell phenotypes in or genotype in the area, is there any progress on that? And if Yes, so do you depend totally on hemoglobin electrophoresis, or do you need to do genetic testing to accurately classify the types of hemoglobin syndromes in the area?
Phenotyping or genotype of the sickle cell disease is still we are in our country is lacking behind. No further investigations usually done. Only sporadic study from here and there. Usually in the previous study or there is most common hemoglobin, sickle cell haplotype we having benign is African haplotype, and usually in the eastern region and Hassa regions also having the Asian or Indian Asian haplotype, which are more clinically or weak clinical manifestation because having high hemoglobin F. Usually Indian type or Asian haplotype usually having more hemoglobin F levels when do electrophoresis. This is the hint only, and we can do it from electrophoresis. Usually African type have less hemoglobin F or normal hemoglobin F, less than 1 or 2 maximum. So this is one of the cases can help it, but for genotyping, phenotyping is still lacking behind. Only sporadic cases, and need the society or some governmental approach for that.
Thank you. So if you can ask Dr. Fahad also regarding the selection of iron chelation for patients with thalassemia, what are the which agent you will select for your patient? For me, I usually use the oral. I don't know if the oral is enough in some patients or not. Given the fact that the other agents are very, I mean, lifestyle is, you say, hang to infusion 8 hours per day, every day for 5 days a week. I think lifestyle is not good with this. How do you select according to the patient profile?
Yeah, thank you for this question. Actually, the major challenge we faced with those patients for the iron chelation therapy is the compliance. So I will select mainly based on the, the agent. I will select the agent that I believe this agent will be more convenient for this patient. I will start definitely with tablets. Unless the level of iron is much higher, then I will go to the subcut or IV types. But definitely in the beginning, I will start with the tablet type. Combination have been used, and actually we use it in our center. In Prince Mohammed bin Nasser Hospital, we used a combination of 2 medications. And in one patient, we used a combination of 3 medications actually. And we achieved good results. Alhamdulillah. So combination is applicable also.
Okay, Dr. Usman.
Assalamu alaikum. Thank you for your presentations. It's just a comments for the IV Disferal. What we are using in Al-Hada, there is a sort of a portable device mainly used for chemotherapy infusion. They call it full fuser. It has a different infusion rates starting from 1 ml per hour up to 10 ml per hour. We are bringing the patients to the daycare unit for 4 days a week. We are fixing the device, put the medication, and they go home with it without the need for admission. And this did help us a lot to avoid admissions and to help patients, especially those who are in need for a combination therapy. The oral may not be effective because of the compliance. So we are using this device and did help us a lot in this regard. We are giving it maybe for 2 weeks. Patients comes, now we have a device that can be hooked for a patient for 48 hours. And there is another one available in some other centers. It can be used for more than that. This might help whenever there is a need for the IV desferal infusion without the need for admission. Thank you.
Thank you. So we have a question from the online virtual, I think for Dr. Ayman. Female has low MCV, MCH, and hemoglobin F 3.6, hemoglobin A2 3.2, iron normal. What is the diagnosis, especially if the genetic test is not available? Other partner has beta thalassemia trait.
is يعني ها الشاشة the case is not easy يعني low MCP, low MCH with high hemoglobin F 3.5 or 3.6 and hemoglobin A2 3.2. We need to look at the chromatographics. We need to see the paper from the machine itself to be يعني interpreted the result. It's not easy to interpret it in this limited informations. Huh?
Our lab. What is the upper limit for A2 in our lab? Is 3.5 or how?
Depend on the machine use it. If you use hemoglobin, HbA1c, usually the upper limit to up 3.5. If you use the capillary, usually 3.2, 3.3 also. The 3 is enough sometimes. But depend on the validations and which machine to use it. These cases need to be repeated first and know the age of the patient and how come sometimes we need to do if the father and mother is still alive, maybe helpful to do the electrophoresis also in these cases.
Last comment.
I understand the difficulty. The questions from this doctor, he mentioned that genetic test is not available, and in this pre-writer screen, he need answer for the counseling session. So, what if I am in his place? I should clear for marriage, or you are not clear, or you should to do genetic test to be sure that you don't have the risk of what we can that the marriage will be risky for them.
Because his hemoglobin F is here is more than normal, and is 3.6 should be less than 1, maximum 2. It can be accepted. This could be one of the rare conditions. We need to the ethnicity of the group of this age. This patient is Saudi, non-Saudi, from which area, and also to look at the chromatography. Maybe Dr. Adnan have any comment here for this case?
Can give you my advice.
Thank you, Dr. Ayman. I think I see the chromatography for this patient and capillary and repeat the test again. This, I think, from our region, from Dr. Ahmed, and the patient from our region also. The CBC is coming with thalassaemic pictures, and the hemoglobin F is high, and A2 is borderline. For me, this need a mandatory genetic test to rule out thalassemia because the other partner have beta thalassemia. Like this case, but sometimes we found hemoglobin F within normal, and we found a lot of cases CBC is going with thalassaemic pictures, and the other partner may be sickle cell trait or beta thalassemia. We have difficult to make a decision, and our recommendation to do molecular, but we don't have access to do molecular in our regions. Here the question is better how to make the access to those for some patient or for some pre-marital test
easy to do molecular test to rule out beta thalassemia with normal A2 and thalassaemic pictures from CBC, low MCV, MCH, and high RBC count. I don't know who.
That done on the capillary or SVs?
I think most of them.
Both.
Yeah.
If the capillary is the 3.5, 4.2.
I think this in the capillary.
3.2,
I think I have the graph here. He sent to me the last week. But the main questions is how to get easy access to moleculars.
This cases need the molecular now.
Yeah, in each studies.
Okay, thank you.
Is not available in the international program for pre-marital is stopping on in the electrophoresis only. These cases maybe need genetics testing. Thank you.
Okay, thank you, Dr. Ayman. Thank you, Dr. Fahad, for discussion. So by this, I will conclude this session, and the next session will be with Dr. Hafiz.
Assalamu alaikum. We'll go for the last talk before we go to the prayer and lunch sessions. Dr. Abdullah Zaid will present his talk about thalassemia current management versus the future advance. Dr. Abdullah Zaid is adult hematology consultant and chairman of inherited blood disorder in Qatif Central Hospital. Dr. Abdullah, one of the experts in sickle cell anemia and thalassemia, and one of our reference. Thank you, Abdullah.
Thank you very much, Dr. Hafid, for the nice introduction. And I would like to thank the organizing committee for inviting me to be with you today with this kind people here, and extend my gratitude to the BMS the company for sponsoring this satellite symposium. And I would just... Thanks. So my talk will be about beta thalassemia current and future advances. And this is a disclaimer that this activity is scientific activity sponsored by BMS. And my talk will be in two parts. The first part will be an introduction and a brief highlights on the new nomenclature, as well as the complication of both thalassemia, alpha and beta, transfusion dependent and non-transfusion dependent. And then I'll move to the bulk of my presentation, which is the novel therapy on thalassemia. These two cartoons are 2 decades of age, and I would not go in deep with explaining the pathophysiology as being already discussed by Dr. Fahad. I thank him for setting the stage for me, and I would just say in a nutshell, the thalassemia is basically a chronic anemia and hemolysis due to ineffective erythropoiesis that will lead to iron overload. I'll revisit the pathophysiology later on in the novel therapy, because I have to highlight some points to understand the mechanism of some of the novel therapies. So I still remember when I was a medical student trying to memorize this thalassemia syndrome, and as the classical teaching knowing about thalassemia major, intermediate, and trait. And interestingly, when I was preparing my talk, the thalassemia syndrome about 2 articles in New England Journal of Medicine. The first one was 2005, and the second one was in 2021. And you can see here that the major highlight was on the transfusion part. And this why we are in the practical aspect, we rely on the symptoms of the patient. And we know that some patients, they have completely no symptoms, and this is basically the alpha thalassemia trait and beta thalassemia minor, while patients, they have mild to moderate symptoms, and this is what's called the non-transfusion dependent thalassemia, because they seldom require transfusion, or sometimes occasional, and during the stress situation like pregnancy and infection and surgeries. And some patients, they may require intermittent transfusion. However, there is the severe disease, those patients who are a regular lifelong transfusion, and this is what's called the transfusion dependent thalassemia, and consistent with beta thalassemia major, severe hemoglobin A beta thalassemia, or hemoglobin bars hydrops fetalis. So the complications, it's now not acceptable to see these jumping fascias because this means that the patient was not properly managed. And as a matter of fact, we know that the complication of thalassemia is being affected by iron overload, ineffective erythropoiesis, and anemia. These three interchangeably affecting the body that will lead ultimately to organ damage, whether in the heart or the liver. And when we see a patient who is on transfusion-dependent thalassemia with these complications, this means that this patient is inadequately transfused or irregularly followed up or improperly managed. However, in the non-transfusion-dependent thalassemia, those patients do not come to the clinic usually because they are most of the time asymptomatic, and that's why the complications are more worrisome in those cases because they will have cardiopulmonary complications, osteoporosis, venous thrombosis, and iliac ulcers, as well as the other complications. These outlines summarize how we should manage the thalassemia. Some patients, they may require splenectomy in order to alleviate the anemia, but this will be on the expense of developing hypercoagulable state. Some patient, which is definitely for the transfusion-dependent thalassemia, they will require transfusion to treat both the ineffective erythropoiesis and the anemia, and this ultimately will lead to secondary iron overload, where iron chelation therapy has to be introduced in order to treat the secondary iron overload or even the primary iron overload due to increase in the absorption of the iron. However, timing of transfusion is really very crucial. Lower hemoglobin level was associated with more frequent complications in both transfusion-dependent thalassemia and non-transfusion-dependent thalassemia. And if you look at the latest guidelines of the Thalassemia International Federation, which was published last year, you can see that the main goal of physicians is to monitor, to prevent, and manage the complication. And I have to add here that we have always to consider the eligibility of the patient to go into clinical trials. If the patient is eligible for stem cell transplant, they should go for it. And if the patient age is 18 and above, then we should consider luspatercept, and we have to monitor for iron overload. And the iron overload has to be closely monitored in order to avoid any end organ damage, and chelation therapy has to be started whenever there is evidence of iron overload, or sometimes even a high ferritin of above 1,000. With regards to the non-transfusion dependent thalassemia, similarly, we have to advocate the patient should go also to clinical trials whenever it is possible, but those patients who require blood transfusion, especially below 10, hemoglobin of 10 and below, should be closely monitored for iron overload, and the iron chelation has to be started to avoid end organ damage. Now, moving to the bulk of my presentation, which is the novel therapy. And as you can see here from this cartoon, there are multiple targeted points, and each point can arise into a novel therapy. And as I summarize this in this cartoon, I will this be seen and to the rest of my lecture. So either we directly target the impaired alpha beta globin ratio, or we go to the ineffective erythropoiesis or hemolysis, or targeting the iron overload. And to start with, always stem cell transplant is first as an option, because the patient is between two possibilities: either to stay on blood transfusion and become dependent on the blood transfusion, treating all the complications, or we go to the curative option, which is the stem cell transplant, with possible of complication like infections, graft failure, or graft versus host disease. And we know we do not need graft versus malignancy in this case, because this is a benign disease. And because not all patients has a matching donor, that's why we have to think of an alternative for the stem cell transplant. That's why gene therapy comes here, and the thalassemia was among the first genetic diseases for which gene therapy was proposed, and it can be either by gene addition or insertion, or it can be by gene correction or addition. And talking about the gene insertion, these are basically two parallel processes where we can get the apheresis from the stem cells from the patient and get these cells purified, transfused, and then cryopreserved. While the patient during this phase will receive the conditioning from day -5 to -1 till day 0, where we get these cells and fuse them back to the patient. And with regards to the clinical trials and the products, there are three main products. The first one is the beta-glucine autotemcel, and shortly known as BETCEL, and this passed already on phase 1, 2, and 3, and there is also ongoing prospective long-term follow-up. The other two are still on phase 1 and 2 phase clinical trial. You can see from this phase 1 and 2, HGB 204 and HGB 205 trials, which was done on the beta cell autotemcel. It enrolled 22 patients who are transfusion-dependent thalassemia. 12 out of 13 were has stopped the RBC transfusion. Non-patients with beta not genotype has decreased by 73% and discontinued in 3 patients with acceptable side effects. It's just like any autologous stem cell transplant. From the diagram here, you can see that the improvement in the hemoglobin from 8.2 to 13.7, which is very good result in these patients. Another interim phase 3 data at HGB 207 and HGB 212 trials has enrolled 41 patients and followed up over 24.3 months, and transfusion independence was achieved on 88.2% of transfusion. And there is also similarly 27 pediatric patients with similar result to the adult patients. In last August, the first cell-based gene therapy was approved by US FDA for this for patients with transfusion-dependent thalassemia, and Zynteglo is now the first drug for thalassemia, beta thalassemia or transfusion-dependent, and is now the second most expensive drug on the planet for one single infusion. Moving toward the hemoglobin F induction, as we all know that elevation of hemoglobin F can ameliorate the morbidity of the beta thalassemia, and as a matter of fact, it is inversely proportional to hemoglobin, the fetal hemoglobin. As the fetal hemoglobin goes up, the more comorbidity score will be less. And historically speaking, there are multiple drugs has been already tested on thalassemia with as hemoglobin F inducers, and the majority of them show the positive result, although some of them are small in number, but they are still promising. That's why the other alternative gene therapy pathway or approach is the gene editing targeting the BCL11A. We know that just shortly before the birth of the baby, the KLF stimulate the BCL11A that will BCL11A inhibit the formation of the gamma globin chain, and this will lead to a suppression of the fetal hemoglobin production. In the same time, KLF1 will stimulate the production of the adult hemoglobin, and that's why there are gene editing nucleases that can target this pathway by specific nucleases such as zinc finger nuclease or the TALIN or the CRISPR-Cas9, which is the most advanced and most modern type of gene editing. And by switching off the BCL11A, we can increase the hemoglobin F. With regards to the trials, there are two main trials, the CTX001, which is used the CRISPR-Cas9, and the second one is the ST400 zinc finger nuclease. The ClimbThal111 was first in human CRISPR-Cas clinical trial in thalassemia using the CTX001, and it is similarly to the gene insertion, and you can see two parallel phases or two parallel processes where you can collect the stem cells from the patient and modify them using the CRISPR-Cas technology and then cryopreserve them. At the same time, the patient will receive the myeloablative conditioning by busulfan until day 0, where the cells will be transfused to the patient. And in this, the first interim result was published on New England Journal of Medicine in 2021 on 10 transfusion-dependent thalassemia patients, and the engraftment was achieved on a median of 30 to 38.5 days, with increase in the total hemoglobin and hemoglobin F. And the patient has stopped their transfusion within 2 months from the infusion of the CTX001, and the safety profile was just similar to those who received post-sulfide myeloablation and autologous stem cell transplant. More about the hemoglobin F-inducing agents is the tuviontrine, which is known previously as IMR 6A7. Unfortunately, this was announced last year by the company that the drug is not significantly superior to the placebo, and the trial was aborted. On the other hand, benserizide, which is a peripheral decarboxylase inhibitor used in patients with Parkinson's disease, it was found that it can also increase the hemoglobin F. And this drug basically reminds me with the hydroxyurea on 1980s, when they discovered that hydroxyurea can increase the hemoglobin F, and then it was repurposed to be used in sickle cell disease and led to the approval of FDA based on the MSH trial. And hopefully benserizide will go the same pathway. Moving to the alpha chain synthesis reduction. Basically, there are, instead of targeting the beta globin chain impairment, we are targeting the excess of the alpha globin excess. And this has been already tried on animal using the CRISPR-Cas9 as a xenograft assays show the long-term repopulation of the hematopoietic stem cells. So instead of targeting down the hill, we are targeting up the hill in order to make the balance between the alpha and beta thalassemia and paving the way to novel therapeutic agents to be used in beta thalassemia patients. More toward the ineffective erythropoiesis, and here I have to stop and talk about the ineffective erythropoiesis and effective erythropoiesis. We know that it is a very complex process. The erythropoiesis is basically 2 stages. The first stage is the proliferation stage, where erythropoietin take the upper hand, and this is in the proliferation stage, while the latest stage, which is the maturation stage, is controlled by GATA1 and by the TGF-beta superfamily ligands. With more explanation on this, we can look at the normal erythropoiesis. Here in the first stage, in the normal patient, you can see that there is a positive regulation by erythropoietin, and the proliferation is nicely done and completed by the positive regulation by the GATA1, as there is no problem here. So the differentiation and maturation is being smoothly done, and erythrocyte homeostasis is achieved. However, in thalassemia patients, ineffective erythropoiesis is there, and the erythropoietin will be elevated, trying to overcome the anemia. However, there will be also expansion in the erythroid progenitors, but unfortunately, there is no improvement due to the overactivated SMAD2/3 signaling and impaired erythroid maturation that will lead ultimately to anemia. So JAK2 inhibitors was tried as an effective erythropoiesis agent, but it passed phase 1 and phase 2, but did not pass to phase 3, unfortunately. And then the sotatercept and luspatercept came on the scene, and luspatercept won the game. So luspatercept on the BELIEVE trial was the first-in-class investigation erythroid maturation agent that can neutralize the TGF-beta superfamily ligand. So basically, TGF-beta superfamily ligand will come and attach to the activin receptor type 2B, and stimulating a cascade that will lead ultimately to the erythroid inhibition of maturation. So when we use luspatercept, we are inhibiting the TGF-beta superfamily, inhibiting all the cascade downstream, and this will lead ultimately to the inhibition. So inhibition of the inhibition will lead to stimulation and production of the RBC. There are 2 main landmark clinical trials. The first one is the BELIEVE trial, which was published in New England Journal of Medicine in 2020, and this was based on the patients with transfusion-dependent thalassemia. And the second trial was the BEYOND trial, which was firstly published in the European Hematology Association Congress in 2021 on and the non-transfusion dependent thalassemia patients. And the Believe It trial is a randomized, double-blind, placebo-controlled phase 3 study that involved 18-year-old of patients. The total number was 336. They were randomized on 2-to-1, and the first arm is the luspatercept arm, where the patient will receive 1 milligram per kg every 3 weeks. And the second arm is the placebo arm, which will receive only placebo with the supportive care. And then the patient will double blind and will go through double blind period, which is 48 weeks, and then crossover were permitted, and after study and blinding. And the current study now, it's in the open label up to 5 years, and there will be also a post-treatment follow-up, which will be 3 years. The primary endpoint is a 33% reduction from the baseline RBC transfusion burden in weeks 13 to 24. The secondary endpoint was 33% or more reduction in the RBC burden in weeks 37 to 48. The other secondary endpoint is 50% or more reduction from baseline RBC transfusion weeks 13 to 24, or weeks 37 to 48. The mean change from the baseline and the RBC transfusion burden during 13 to 24. And there is additional endpoint, which is 33% or more, or 50% or more reduction in baseline of RBC transfusion burden during any 12 weeks or any 24 weeks on the study. And amazingly, the result was positive in favor of the luspatercept, and it has achieved all the primary and secondary endpoints in comparison to the placebo. You can see here that this is a very safe drug. There was only one death, but in the placebo, not in the luspatercept, due to acute cholecystitis, and the patient passed away in the placebo arm. The safety, the side effects are basically most of the time are bone aches or back aches and arthralgia, and all of them are well manageable. I have 2 patients already on luspatercept. Both of them, they are saying it's very mild. They rarely require paracetamol ingestion. Moving to the second trial, which is the Beyond trial, it was completed last year, March 2022, and was published in the Lancet Hematology in August last year. And this was a phase 2 trial, which has only the non-transfusion dependent thalassemia with hemoglobin of 10 or less. The total number was 145, and they were randomized again in 2-to-1 ratio. The luspatercept arm was similar to the Believe It trial, 1 milligram per kg subcutaneously every 3 weeks, plus the best supportive care, and the placebo arm is similarly with the supportive care. The primary endpoint was the increment of hemoglobin concentration of 1 gram or more in weeks 13 to 24, while the secondary endpoint was more at this time on the symptoms of the patients, quality of life, as well as the physical activity measured by 6 minutes walking test and the iron overload parameters, including the dose of chelators, the liver iron concentration, and the ferritin, plus pharmacodynamics and adverse events. And you can see here from the the blue dots is the placebo, and it is, most of them are centralized at the 0 line. You can see the 0 line here, and most of the blue dots are the 0 line, while the red dots are the luspatercept arm, and they can see there is an improvement in the hemoglobin. So the results showed that the 77% of the patient in the luspatercept has achieved the primary endpoint, in comparison to 0 in the placebo arm, with increment of the hemoglobin of 1 gram and above. And with regards to all the endpoints were statistically significant in all of them. And with regards to the adverse events, again, you can see similar to the Believe trial, mainly aches and headaches and arthralgia, which is manageable. And this is again another side effects that but they are not serious side effects. Moving toward to the PK receptor activator, which is a pyruvate kinase receptor activator. It is the mitapivat. It is the first in class oral small molecule allosteric activator of the RBC specific form. And we know that the ATP is lower in the thalassemia red blood cells. That's why their lifespan is shorter, and that's why they hemolyze easily. And the PK pyruvate kinase receptor, if it is activated, this will generate more ATP and will make the more energy for the RBC to stay alive or have a longer span. So basically, it is an energy booster to the thalassemia that will lead to the improvement of ineffective erythropoiesis, decreasing also in the iron overload and iron the use of iron chelation. And it has been already approved for PKD, the pyruvate kinase deficiency, and been also tried on patients with thalassemia. And there are this trial was a phase 2 trial, which is done on the non-transfusion dependent alpha and beta thalassemia. 20 patients, 5 with alpha thalassemia and 15 with beta thalassemia, with a mean baseline of hemoglobin of 4.9. 16 patients, which is 8% of the patients, had hemoglobin response and reaching 1.3 gram increment. All the patients of the alpha thalassemia and 8 out of 15 patients with the beta thalassemia has sustained response with acceptable side effects. And there is already an ongoing clinical trial, which is basically the Energize-T and Energize trial. So Energize-T is planned to be on adult patients with transfusion-dependent thalassemia, both adult alpha and beta, and planning to enroll 240 patients. It is already started November 2021 and expected to finish on June 2024. The second one is the Energize, which is also planned to be done on the adult patients, non-transfusion dependent thalassemia, both alpha and beta thalassemia, and it plans to enroll 171 patients. It has also started in the same time of the Energize-T on November 2021 and expected to finish this year in December. Moving to the last but not least, the iron overload targeted point, which is the hepcidin analog. And we know that hepcidin is the goalkeeper of the ferroportin, and it is decreased or suppressed in patients with thalassemia. So when it is suppressed, this will lead to stimulation of the ferroportin and iron absorption. And this will lead ultimately to iron overload. There are 3 classes of hepcidin agonists. The first and second one already still either in preclinical or phase 1 trial, but I found the last class is more promising. It has already passed the phase 1, and it is really showed potentially increases the hemoglobin and reduces the iron overload. That will lead to decrease the organ iron overload and decrease the spleen size and decrease ineffective erythropoiesis and anemia. So as we can see that our patients since 1964, they have a prolonged lifespan is continuing. And nowadays we see patients in their 3rd decade or sometimes even 4th and 5th decade. And I have patient already has reached to 50 of age, and hopefully we are going to a longer life and having a normal lifespan in the near future. So in conclusion, blood transfusion and iron chelation is still the main cornerstone of management. Hematopoietic stem cell transplant and gene therapy are still the only curative treatment. As we know more about the pathophysiology and ineffective erythropoiesis, the more the potential therapeutic agents we will be able to produce. Luspatercept is the first molecule registered by the FDA, EMA, and Saudi FDA to treat patients who are transfusion-dependent beta thalassemia. Mitapivat or the PKR activator is still another hope for both transfusion-dependent thalassemia and non-transfusion-dependent thalassemia, both alpha and beta. And hepcidin mimetics still can serve as a good candidate in improving the anemia and ineffective erythropoiesis. Thank you very much.
Thank you very much, Dr. Abdullah, for the advanced review on thalassemia, current and future management. Can you have a seat and we'll receive a few questions before go to the lunch session? Yeah. Any question for Dr. Abdullah? Yes, we can. Yeah, Dr. Saud.
Alaikum. Thank you for your nice review. My question, you get consulted for patient with thalassemia, advanced thalassemia, who are a donor, solid organ donor for kidney, liver. So any special recommendation for those donors, so they are the only donors for their brother, their sister, their fathers. Any special recommendation for those patients?
Just to clarify the question that I understood it very well. So you're talking about the patient being the donor or the patient is the recipient?
Thalassemia patients who are a solid organ donor for their family, like they're gonna donate part of their liver, they're gonna they wanna donate kidney for one of their relatives. So any special recommendations? Do you allow them? Number one, and is there any special recommendation for them?
Well, it all depends on if there is any alternative. Like if there is somebody else that can donate, I would definitely go for that healthy person, because this patient, though they may not be manifesting iron overload, but they might have settled iron overload that is not being easily discovered. Especially what we have as a routine screening is the ferritin and the MRI, which is the LIC and T2 star for the cardiac. But like if let's say that the patient is going for kidney donation, we don't have any imaging for the kidney. That's why we cannot say yes or no. What I would recommend is to avoid the patient being a donor.
Ibrahim.
Thank you, Dr. Abdullah. Very nice presentation. I have two questions regarding gene therapy. The first question is why the attempt of doing like insertion of normal beta globulin gene rather than using disease modifying approaches, increasing hemoglobin F or reducing alpha thalassemia. Is there an attempt to introduce the normal gene in the stem cell?
Right. So the first one is this is let's say the old technique. It's not old, it's still recent, but the insertion, which is the lentiviral the lentivirus, is what we got the normal gene. It's like having it in an envelope, the virus itself, and giving it to the patient in order to be in the machinery of the cells of the patient, so they can produce normal hemoglobin. So this is now not, I would say it is the approved one, but the trend is to go with the addition, the CRISPR-Cas9. So that one is, there are a lot of issues with regards to the purification and even in the 1990s, this was the technique, and it was helped because there was activation of the virus and there was a lot of dilemma in this issue. So if we can use a pure viral vector that can give us the outcome, better outcome, definitely this will be work as in the Zynteglo, it is being approved for this. But the CRISPR-Cas9, it is more advanced, and the trend nowadays to use CRISPR-Cas9 technique.
Okay, so the second question, the time frame of getting this modality of therapy to the clinical practice, how long you think it need time, and if it is like assume that it got approved here in Saudi Arabia, do you think, because majority of patients are in Jazan and Al-Hasa, do you think non-transplant center can build their infrastructure to do these therapies, or they should be referred to transplant centers?
Right. I will start with the second question. You can, as in Jazan, as in our hospital in Ahsa, we are non-transplant center and we can do gene therapy because it is not sophisticated. All what we need is a collaborative work with the company that manufacture the gene therapy. So it's easy. It's just to say, I would like to have this. You have to have a GMP lab in your hospital where you can store these cells for the patient to be infused with these cells. And with regards to the how long would it take, this is not easy to be answered, because even regular drugs like medication, like luspatercept, it was approved many years, but took a while to be approved. There are many drugs for sickle cell, for example. Up to this moment, they are not yet approved, and this is, the authority and the control is difficult to guess how long would it takes to be approved.
No, I mean the time to become standard of care, not to be available. I mean standard of care worldwide. I mean,
For
is it
to be-
approved therapy now?
It's already approved by the US FDA. So that's for the gene insertion, not for the CRISPR-Cas. For the CRISPR-Cas line, it's still not yet approved.
Yeah, Dr. Anos and then Dr. Hamid.
Dr. Abdullah, I have a question. Now, the more practice we learn from, sometimes you have, like what happened recently in COVID-19, the donations, the donors of blood become less. So we think of alternatives. So, plus, in addition, the side effect of blood transfusions, low immune, and you with many difficult immunosuppressive therapies. And I think it was approved hydroxyurea for the beta thalassemia intermediate, but till now what's not approved, or maybe there were no clinical trial for the major. I don't know, do you have any comment? Sometimes anybody use it before, any benefit or any side effect from it? If I want to increase the hemoglobin F, I mean, it might be possible in beta thalassemia, but I don't.
Please, short question for the time. So your question about hydroxyurea.
Any previous comment or trials about hydroxyurea and beta thalassemia major?
Yeah, it's being used already, and I do use it in selected patients, but the response is not very, very impressive. They do respond. They may be able to delay the transfusion by a few days or a week, but it's not very impressive, though it is, I would say, beneficial. In certain group of patients, they may improve. I have a patient who has a beta thalassemia major, but not transfusion dependent. During pregnancy, she had alloimmunization. I could not give her any blood. There was no matching the blood for her. I had to use hydroxyurea. Her hemoglobin was in the range of hemoglobin of 5 during pregnancy, and she's post-delivery. She's having hemoglobin of 9 and around 10. So this is only with hydroxyurea. There are a lot of, I mean, even in Iran, they use also hydroxyurea for certain patients.
Okay, thank you.
Dr. Hamid, yes.
Assalamu alaikum. Very nice presentation.
Thank you.
Thank you very much. Just about 10 years ago, so I did a sort of an economic study on the financial burden of hereditary blood disorders. And I looked into thalassemics and sicklers. And I'll give you a number that I reached at that time for patients with thalassemia. All costs, direct and indirect, to reach the age of 40 came to more than 10 million Saudi riyals for each patient.
Yeah.
From the day of birth all the way to 40 years. So this is huge expense on the country. I know that some of the medications are rather expensive, but I think we have to look into that in the perspective of the total cost, not only a single dose or so. So this is, I think, worth revisiting with the new medications and also the new current practice available.
Very nice comment. Thank you very much. Then this is like a nice coincidence when you say 10 million Saudi riyal. This integral is 2.8 US dollar, which is equal to 10 million Saudi riyal. And if we want to think which one is more cost effective, you would say, well, if I can do it for a child, gene therapy, though this is not approved for children, it's for adults. I mean, the gene therapy, you can like make the patient live normal life with this 10 million Saudi riyal.
Yeah. And that's only until the age of 40.
Yeah.
I mean, it was 12 million Saudi riyal from the age of 40.
Great. Thank you.
Thank you very much. For the last question, any question, or we can move to the lunch and the prayer. Thank you. Thank you, Dr. Abdullah. We're enjoying the presentation and discussion as usual, expected from you. Thank you very much.
Thank you very much. Appreciate it. Thank you.
بنشوة السحر في الغروب والليل والبدر في كيانه على روى الشاطئ الضروب جازان يا درة الجنوب جازان يا درة الجنوب ليك شوق مطلق من هوى كل قلب إليك شوق يا درة الجنوب البدر من نعيم القصيد لكل قلب إليك شوق مطلق البحر والصخر فيك يزهو بنشوة السحر في الغروب البحر والصخر فيك يزهو بنشوة السحر في الغروب والليل والبدر فيك يلهو على روى الشاطئ الضروب جازان يا درة الجنوب جازان يا درة الجنوب البدر من نعيم القصيد لكل قلب إليك شوق مطلق وأنت في روعة المثاني وسحرها الفاتن العولي وأنت في روعة المثاني وسحرها الفاتن العولي عروسة الشعر والأغاني ومنية النفس والقلوب جازان يا درة الجنوب جازان يا درة الجنوب البدر من نعيم القصيد لكل قلب إليك شوق مطلق وأنت الهوى المصفى للفن والحب والحبيب وأنت الهوى المصفى للفن والحب والحبيب جازان يا درة الجنوب الباسل الناعم القصيد جازان يا درة الجنوب جازان يا درة الجنوب الباسل الناعم القصيد لكل قلب إليك شوق مدحر من هوى وطيب
the company, they will do it outside the region, the kingdom, maybe in Germany or something like this. And usually we get the result within 2 weeks from the sending the sample. The company has no intervention with the result. It's very confidential to sending the physician who's sending the sample. At the end, thank you very much. It's only very simple hint to that this disease underestimated, and please to consider it in your differential diagnosis for a patient with thrombocytopenia, anemia, and organomegaly. Thank you. Because of the time management, I will skip the questions. We'll move to the next presentation by Dr. Wael. Again, we'll have another real world or local experience for the novel agent patient with thalassemia. Yes, Dr. Wael. Dr. Wael is a senior registrar in our hospital and one of the most active specialists. And I think he was a teacher for one of some of the consultants in our department.
Thank you, Dr. Hafid. I will present just a few slides about our experience with the use of luspatercept in transfusion-dependent beta thalassemia patients in our department. First, I want to say that beta thalassemia major transfusion-dependent patients following our daycare units are around 53 patients now. They are under regular follow-up, representing 17% of the total daycare patients in the regular transfusion program. We experienced only just 2 patients with beta thalassemia major transfusion dependent with the luspatercept. They started from October 2021. Until now, they received up to total 20 doses of the drug. Patient number 1 was a male of 27 years old. He is transfusion dependent beta thalassemia, splenectomized at the age of 21 years. Before 1 year and a half and 4 months, he started at the age of 1 year and 5 months, he started the regular red blood cell transfusion. He's defruxamine allergy, non-compliant also to oral medication for iron chelating agents. His baseline hemoglobin was 5.1 and usually he didn't achieve any target hemoglobin pre-transfusion. He started at the age of 18 years, started the treatment of iron chelating therapy without compliance. His serum ferritin prior to the use of luspatercept was 12,219. He's with primary education, non-worker. His blood group was O negative, and this is very bad news for us because blood bank is not easily obtaining blood for him. And he developed also that positive for plus for a long time. He's also, as I said, allergic to defruxamine and non-compliant with oral medication. And he developed osteoporosis with bronzy skin. Now he is managed by endocrinologist. Second patient is a female of 20 years old. She's a university student. Her weight is 59 kg. Splenectomized also at the age of 14 years. Started the transfusion program since 1 year and 2 months. She's mildly compliant to the oral, but usually she received the parenteral defruxamine in the form of BUM. But because she is a university student, she feels shame to take the BUM with her to the university. That's why she's usually refused to take defruxamine BUM. Her blood group is A positive. This is the basic data for prior to the start of luspatercept, and after the start from 1 cycle to cycle 10, and this is the next one from cycle 11 to cycle 20. I will summarize in small figures. just only to explain that, for example, the hemoglobin level in these two patients, patient number 1 in the blue color, the baseline was 5.1 gram per deciliter. And on each visit, taking every 3 weeks, they were taking the luspatercept in a dose of, started with a dose of 1 milligram per kg. And this patient escalated the dose after the third dose up to 1.25 milligram per kg. His hemoglobin was fluctuating, but overall it is over the baseline prior to the start of luspatercept, and in the last visit it was around 8.3 or 8.2. The second one is the female with the red color. Her baseline hemoglobin was 6, and this patient showed dramatic increase in the hemoglobin before, but escalated after the third dose also, because her hemoglobin started at 7.8. Then it increased up to 9 and reaching 9 also in the last visit after 20 doses of luspatercept. Regarding the iron serum ferritin or iron overload in these two patients, the first one started with very high or severe iron overload, but this patient, due to his allergy to deferoxamine, we put him on 2 types of oral iron chelating agents, the deferriprone plus the deferazinox. And his ferritin level decreased in association with the decrease of requirements for the blood transfusion. In the last visit, it was 2,324, and the patient also didn't believe. The second one was the female, started with prior to the luspatercept. Her ferritin was 3,200. It decreased up to 1,460 in spite of her mild compliance with the medication. This is the transfusion burden overall for the two patients. For example, with the number of units, in the first patient with the use of luspatercept around 20 cycles, we achieved a rate of 62.5% reduction in the use of the blood transfusion. And within the mean hemoglobin level, there is a variable 2.3 increment in the hemoglobin level from the baseline to the last hemoglobin after 20 cycles of luspatercept. The serum ferritin also was decreased in about 81% from the baseline to the last cycle. Patient number 2 also showed similar effect, but slightly little bit. The requirement decreased by 50%, and the hemoglobin increased by 2.2 from the baseline, and the serum ferritin decreased with a level of 54.4% since the start of the prior to luspatercept. These are in short our data about these two patients, but we hope that we can include more patients up to 10 or more in order to have a better conclusion and recommendation for such usage of luspatercept. That's why I didn't have any conclusion or recommendation in this. Thank you.
Thank you, Dr. Weil, for the nice presentation. Any question before we move to the next sessions? Mike, brother.
The dose, did you need to increase the dose? The dose increment is after how many weeks you start to think to increase? Like the second patient with the red, is just because the hemoglobin dropped, then you increase the dose for it?
There was a need for increment of the dose in both patients. The first one after the third cycle and the second one after the fourth cycle. When we saw that the hemoglobin, in spite of the using 3 cycles and more, the hemoglobin still not achieving the target increment. And the patient still in need for transfusion of at least 2 units at that time.
And Dr.
We increased to 1.25.
And you mentioned about the bump. From where you get the bump for the deferoxamine?
We have.
Really?
We have no.
Before,
before 1 year, we have the full adult bumps. Now they are available, but they are used by the oncology department for chemotherapy. They have the Fulfex and Fulferi, needs the patient to take the pump with the chemotherapy for more than 24 hours.
So is it
So now we are not using this ideal pump. We are using the pediatric pumps. We have pediatric pumps small for 1 day or 2 days. There is also another pump for 12 hours. We have a lot of options.
Is it provided by the MOH or by the company?
Thank you.
Thank you very much. Will you share the session? I can do it.
Now we will move to the last session in this meeting, and I would like to introduce Dr. Saud Al-Haili, an adult hematologist, a consultant of bone marrow transplant and cellular therapy in King Faisal Specialized Hospital in Riyadh. Dr. Saud is involved in many local and international researches with special interest in multiple myeloma. Welcome, Dr. Saud, and he will present for us treatment of myeloma in transplant ineligible patients.
Assalamu alaikum. I would like to thank the organizing committee for the kind invitation. They always leave myeloma, after lunch, so I don't know why. They start with leukemia, lymphoma, and they leave myeloma to the end. Okay. So my outline today will review the guidelines for treatment of patients with transplant ineligible multiple myeloma. Then we'll examine those guidelines, and we'll come to a conclusion about what should you use, what's easy to be used for those patients, including first option and other options. So we'll examine first the guidelines. So if you go to the MSMART, the Mayo Clinic guidelines, they indicate like patients who are transplant ineligible, regardless if they are standard risk or high risk to be treated with a DRD, that the first choice, or VRD for 9 cycles, followed by lenalidomide maintenance. And it's also the same for the European updated ISMO 2021 guidelines. If you see the transplant ineligible, the first option is the DRD, then the VMB, which is the Spanish regimen, or a VRD for 9 to 12 cycles, followed by Revlimid maintenance. So if you want to follow the guidelines, a DARA containing regimen, including DRD or DARA VMP, is the recommended option. And also the NCCN guideline 2023 updated one, the DRDs remain the first line of option, including also VRD. Other recommendation, you can give RD, KRD, or DARA VMP, this based on the evidence. So if you wanna, those guideline recommendation usually comes from phase 3 clinical trial, which we will see. So we'll start with the Alcyon, which is a phase 3 for transplant ineligible newly diagnosed multiple myeloma with acceptable organ function and creatinine clearance. So basically around 700 patients were randomized to DARA VMP or a VMP, followed by DARA maintenance for those who are on the DARA arm. And if you want to see, around 90% of the patient, they are above the age of 65, with 30% above the age of 75. So this usually represents your patient characteristic for transplant ineligible patients. And, with DARA VMB showed a deeper response and a higher overall response rate of around 91% compared to 74%. And this translated into MRD negativity. 1/3 of those patients are MRD negative in the DARA group, compared only 6%. And this also, those patients who are MRD negative, they were able to sustain that MRD negativity. And we know that MRD negativity is a surrogate endpoint for most of the trials since 2018, and it has been approved by US FDA and the EMA as a primary endpoint, because basically MRD negativity correlates with both overall survival and progression-free survival. And this higher response rate, deeper response, and able to sustain the MRD negativity basically translate into better PFS. If you see the median PFS is around 36 months compared to 19 months. So you almost you have double median PFS on the DARA group. And this also translates into better overall survival around by 42-month follow-up. 75% were alive on the DARA VMP group compared to the BMP group. So DARA VMP is an option. I know it's being used only in Spain, but this at least it's one of your options for transplant ineligible. And this has been based on phase 3 trial and it should improve in both PFS and overall survival. And people were always afraid of side effect if you add DARA to any induction group. And if you see the hematological side effect were almost comparable in both groups. However, which is suspected, those patients at higher risk of infection, 13% compared to 4.2%, slightly higher risk of hypertension. However, death or discontinuation was similar between both groups. So this is a very famous trial that led to now after this trial, DARA RD is the first option in MSMART, in NCC guideline, and in the ESMO guideline 2021. And most centers, even across Europe, they have moved to this one because VMP is difficult to be given, and this is more practical use. So it's basically more than 700 patients, transplant ineligible. They were both randomized to DRD or an RD group. The primary endpoint was PFS. And if you see 80% above the age of 70, so usually this represents your patient group. ECHO was up to 2 with, if you see those patients who are on the DR group, they have higher overall response rate and also higher VGPR or more compared to the standard arm, which is the RD group. And this has led also to deeper response with almost 1/3 of those patients on the DARA group, they are MRD negative, and they were able to sustain that MRD negativity. And this, if we have a higher response rate and deeper response, if you want to examine about or subgroup analysis, if you see this is almost across all subgroup analysis is favored to the DR, whether you're below the age of 75 or above, whether your creatinine clearance is less than 60 or more, ISS group 2 or 3, they benefit DARA more, and all echo group high risk more than standard risk cytogenetics, they favor DARA group. And this, when you see a deeper response rate, patients were able to sustain that MRD negativity, you know, this will always translate into better PFS. So if you see 4-year PFS is 60% compared to 38%, and this has been translated into overall survival. The 5-year follow-up showed, you know, higher overall survival in patients with the DARA group. So from those 2 phase 3 trials, we know that DARA containing frontline, even for transplant ineligible, showed improved PFS and improve overall survival with an acceptable side effect and you know, safety margin for those patients. So the other option that has been you know, mentioned in the MSMART, in the ESMO guideline, and in the NCCN guideline is the VRD, and we know this is very famous, the SWOG 777 trial, but that was in usually for newly diagnosed phase 3, and this is for mainly transplant. It has transplant eligible and ineligible arms, so people, they were reluctant because of tolerability to change this or translate this into transplant ineligible. However, you know that in 2014, the ASH abstract, they did the modified VRD. Basically, in the SWOG, the Velcade is given twice weekly, while in the modified one, the Velcade is given once weekly for those patients. The lenalidomide was 25 milligram for patients who are on the initial SWOG trial. The modified one has 15 milligram and even 10 milligram. It depends. And the steroid, we know that it is once weekly and around 20 milligram for most of patients. And if you see this from this phase 2 trial, It showed that overall response is around 90%, more than 50% that they achieve a very good partial response or more. And only 3 patients were had discontinuation due to side effects. And this has been updated and published in the British Journal of Hematology in 2018 with they have added more and more patients and showed still overall response around 85%, with around 40 to 50% they achieve very good partial response. And this has been validated in different trials or different population, including patient, this phase 2 trial from Japan also confirmed, which was published in the Blood initially as an abstract, showed that also overall response rate is around 85%, CR rate around 15%, very good partial response is around 40%, so around 50% of very good partial response or more. So if that patient is a frail patient, is elderly, doesn't want to come for a weekly daratumumab for the first 2 months, then every other week, prefer or oral medication. So what are other options you can give for patient if they are intolerant to daratumumab or difficult to give daratumumab? So the first is just to give an RD, and RD has been approved as induction for patients who are transplant ineligible based on the first trial that showed median PFS of around 2 years and 4-year overall survival of around 60% for those patients. And so that's one option. What about if patient, steroid, is, as we know, most of transplant ineligible, they have other comorbidities, they have diabetes, they are steroid usually affect them. They have this high energy the beginning of the week when they get steroid, and the end of the week they start to be they have difficulty with daily activity, they're frail. So this is the IFM 2017 for phase 3 trial that comparing darolutamide, so that steroid free arm, to the RD group. So basically they, as we know, steroid showed some side effects, difficult for patient elderly, osteoporosis. So that's why they try to examine a steroid-free arm. And this is, a phase 3 trial that around 300 patients were randomized to DR, which is daratumumab and lenalidomide. The first 2 cycles of the DR patient received steroid because of risk of allergy around 20 milligram, but that's what was only for the first 2 cycles compared to the RD group. So this is an ASH abstract, has a short follow-up. However, it showed a higher overall response rate on the DR group compared to the RD group, and CR rate was around 17% as well. 10% they were achieved MRD negativity. So from this, and what about side effects? Always they're afraid for those frail patient elderly about side effect of daratumumab, risk of infection, including COVID-19, and basically they have a comparable side effect, slightly higher cytopenia. However, grade 3 or more infection, COVID and non-COVID and pneumonia, was comparable in both arms, and that was across all frailty group patients. So if you see if their frailty score 2 to 3 or 4 to 5, the p-value was not statistically different in both groups. So that's the first regimen that is steroid-free in patient. And from this, I know it's an early conclusion. However, at least you have higher overall response rate. They have a higher MRD negativity, acceptable side effect and safety margin. So you can shift your patient if you're afraid of steroid, if they are diabetic, difficult to control, to this steroid-free regimen. The other option is, which was published 2 years ago as an ASH abstract, then full study. It's an Italian study. They basically, those transplant ineligible, they above the age of 65, they were randomized to RD for 9 cycles. Then they stop the steroid and continue on Revlimid with a lower dose of 10 milligram compared to standard of care, which is an RD continuous therapy. And basically, if you see, the PFS and overall survival was comparable with a median follow-up of 40 months across both groups. And they, so this is one option. So the first option, if you can get off steroid is to give daratumumab. The other option is you give 9 cycles of RD, then you shift into the maintenance phase. You know, we always have a question, what about those borderline, should they push for a transplant or not? So this is another ASH abstract presented this year. It's a phase 3 study. Basically, they randomize those who are borderline, you're not sure, to give RD followed by lower dose of melphalan, 140, or a continuous RD for those patient transplant ineligible 60 to 75 of age. So basically, this is how they were randomized, around 350 patients. And if you see the PFS, whether was comparable in both group, whether you might say maybe those who are younger, around the age of 60, they will benefit of a transplant. Basically, they did not compare even the older group, and overall survival was comparable in both group. Even if you want to separate it by stage, so you might say that lower or even aggressive disease, they might benefit of a transplant. So basically they did not benefit of a transplant. So basically this might solve a question: should I push for a transplant, give them a lower dose of melphalan 140? Basically this study, I know it's not an optimal induction regimen, the RD, which is usually we don't use it as an induction pre-transplant. However, it gives you a hint that those patients, they might not benefit of a transplant. If you have a borderline, you're not sure. Other option now available, the median PFS is around, they're saying around 4 years of the DARA RD group. So you have another option with less toxic regimen. We know those elderly who go into transplant, they usually have around 3 to 6 months of fatigue and prolonged side effect with the transplant. So transplant is not an option. So just to conclude, so first line is across all guidelines, and if we see the DARA RD, recently we start to use DARA RD, and I can show you a patient who presented with free kappa of 33,000, and just after 2 cycles, it just normalized. How good and how fast effect of those patients. We usually used to give them VCD, VRD, or an RD, but now we have many patients on the DRD. We have not across any side effect or major toxicity. Very good response within 2 months. The patient experienced a very good response rate. The other option, which is also recommended, is to give the modified VRD for 9 to 12 months, then shift to Revlimid maintenance. Other option for those patients who are, you can just give Revlimid dexamethasone if they have patient who lives away, they cannot come weekly, to give the RD continuous. If you want to spare those patients from steroid because of difficulty control diabetes and all of side effect of diabetes, basically you can give them for 9 months, then shift to Revlimid maintenance, or you can give DARA Revlimid only without the dexamethasone for those patients. The other option that has been also examined, the VCD or CyBOR-D for another 9 to 12 months, followed by our maintenance, and that was the guideline up to 2020 in Canada, just to give VCD, then shift patient to Revlimid. And this is based on multiple retrospective study and showed it's as effective as for those who are transplant eligible. So I think I reached to my conclusion. Now, just to conclude, now we're offering DRD CAR T cell for transplant ineligible. So if you have patients, you want to refer for those patients, we have a clinical trial just to give patient for transplant ineligible DRD for 4 to 8 cycle followed by CAR T cell. Thank you.
Thank you, Dr. Suhaid Al-Haili, for this comprehensive presentation about myeloma. I will share you, inshallah, a lot of patients for CAR T cell. Now, I will present Dr. Inas Dammag, Senior Registrar of Adult Hematology, Prince Mohammed bin Nasser Hospital. Dr. Inas is our colleague in the hospital. She is the dynamo of the department. Everyone in the hospital, he knows Dr. Inas because she is contacting every department searching for help for hematology patients. She will present now her topic about the TBO in ITP.
Thank you. Thank you for the presentation. I will speak about thrombopoietin receptor agonists in ITP. First of all, this is my agenda. Sorry. I'll just have a clue about definition, epidemiology, classification of ITP, pathogenesis, which is important before starting my topic, and general management of ITPs as a second line, because I'm not dealing with the first line or third line. And why did we start TPO receptor agonists? What's the mechanism of action, indications, and in pregnancy, the situation with the pregnant ladies. Immune thrombocytopenia or morbus Werfel, as was described first by a German doctor. It is an autoimmune disease characterized by low platelets, less than 100,000 per cubic millimeter. Immune thrombocytopenia occurs in an incidence of about 1.6 to 3.9 per 100,000 patients per year. This incidence rate varies between pediatric and adults. It's more in adults with increasing with age, but usually the pediatric are presented with the acute disease form compared to the adults, which are more in the chronic course of the disease. About 80% of the adult patients go for chronic course. ITP, as we all know, is a disease of exclusion. And first, to diagnose ITP, we first have to exclude the differential diagnosis as we see. For example, drug-induced like HIT, consumption, DIC-TTP or hemolytic uremic syndrome, nutritional causes of thrombocytopenia like B12 deficiency, bone marrow failures like congenital thrombocytopenia, MDS, or infiltration, fibrosis, or radiation to bone marrow. And we have to exclude also splenic sequestration and portal hypertension. There are other secondary causes for secondary ITPs, which we also have to consider, like infections, including HIV, hepatitis C, B, Epstein-Barr virus, H. pylori, autoimmune diseases like systemic lupus, Evans, Sjogren's, whatever autoimmune diseases that can be presented also by immune thrombocytopenia. Hematological malignancies, non-Hodgkin lymphoma, most commonly the CLL, are usually associated with ITPs, primary immunodeficiencies like common variable immunodeficiencies. For diagnosing ITP, we usually do the routines, CBC, peripheral blood smear, virology screening, immunological screening to exclude the secondary causes of ITP. We look for nutritional causes, and in the end, we go for bone marrow study to rule out the bone marrow infiltration or failure. Antibodies against platelets, it's not sensitive, not specific, so it's not in the clinical practice. It could be investigational under trials or any other studies, but it's not in a routine clinical practice because usually they are not specific, non-sensitive, and it can be of the form of IgG, IgA, or IgM, and could target any platelet antigens, glycoproteins, example 2A, 3B, or whatever possible. The disease course classification, usually we call the new ITP patients if they last less than 3 months, persistent if they last between 3 to 12 months from diagnosis, and chronic if they are lasting more than 1 year. There is another term, refractory ITP, if the patient is at risk or display bleeding despite splenectomy, and severe ITP if the presence of bleeding requires treatment or treatment escalation. For pathogenesis or during the course of the disease, we have to keep in mind that ITP is not only the peripheral destruction of platelets, but also there is insufficiency production of megakaryocytes. As we can see here, due to infection or any cause, there is antibody production that will target the certain glycoprotein or receptor on the platelets. The fate of this opsonized platelets, it will undergo apoptosis either by complementary system, antibody and complementary induced apoptosis, or through the T cell CD8 cells that will cause platelet apoptosis. These apoptosis products will increase the expression on the dendritic cells, which are dysregulated, and the inhibitory signals will be downregulated while the stimulatory signals will be upregulated, and will cause further stimulation for both CD4 cells and CD8 T cells. Another thing, also the opsonized platelets will go directly to the macrophages and will be phagocytosed by the macrophages, leading to more antigen expression on the macrophages and further stimulation for CD4 T cells, T helper cells. And this will cause further production of antibodies by stimulating the B cells to form platelet antigen targeting plasma cells, and more antibody production will be the end result. These antibodies will target, as we said before, certain receptors on the platelets that are shared also with the megakaryocytes. So the bone marrow will be also affected by these free antibodies, and which will go and attach to the megakaryocytes, leading to apoptosis in the megakaryocytes induced either by macrophages or CD8 positive cells, T cells, and it will also reduce the production of platelets from these megakaryocytes. This is the general overview for pathogenesis. And this is another same thing. So the management for ITP, as updated by the American Society for Hematology in 2019, suggests that initially we all agree that steroids is the baseline for treatment in any ITP. Either pulse steroids or low-dose steroids, whatever we will give, the steroids are the first line of therapy. If the patient is at risk of bleeding, or if you think that the patient needs to be escalated fast, you can give human immunoglobulin or anti-D to escalate the platelet production, or reduce the destruction. But if the patient exceeds 3 months of history with ITP and is not recovering, what is next? Steroid for long term will cause more complication from the steroids itself, and usually the patient will not be that good a responder, or maybe refractory to steroid. So I need to start the second line. Previously, second line consisted only of splenectomy and rituximab. Nowadays, we are having this option of thrombopoietin receptor agonist. And here, the ASH recommends that other patients with ITP more than 3 months who are dependent or unresponsive to steroids. First of all, we have to assess the duration of ITP. If 3 to 12 months, and primary treatment options, we have either rituximab or thrombopoietin receptor agonists. We give the option for the patient to decide. Patients who are willing to go for long-term therapy with medications and are compliant with the medications will go for thrombopoietin receptor agonists. Patients who are not willing to go for long-term medications, we can give them rituximab. And if response with thrombopoietin receptor agonists are much better than the rituximab, but we have to give a choice for the patient to decide. If the patient is chronic already above 12 months, then the primary options for us will be rituximab, splenectomy, or thrombopoietin receptor agonists. Keep in mind the thrombopoietin receptor agonist will not abolish the immune process of antibodies to downregulate by itself. Same idea, I will give a patient time to, after assessing the patient values, I will give the option to the patients. If the patient is willing to go for surgery, then splenectomy will be my option. If he is failing or refractory or relapsing again, I can choose a TPO receptor agonist after that. If the patient is trying to avoid long-term medication and refuses surgery, then my option will be rituximab. If then he will relapse and he will agree for splenectomy, I can go for splenectomy. If the patient is avoiding rituximab and avoiding splenectomy due to risk of infection or whatever, then I will have to choose for him TPO receptor agonist. But he should keep in mind that he will be compliant with us. The milestones in ITP, I thought this would be interesting for us. ITP was first described in the 18th century. In 1958, TPO was first described. In 1994, the gene coding for thrombopoietin receptor was discovered. In 2001, all thrombopoietin growth factors were stopped by the FDA because they found that the pegylated recombinant human megakaryocyte growth factor and the recombinant human thrombopoietins caused autoantibodies to be produced targeting the thrombopoietin, and it caused prolonged thrombocytopenia after discontinuation of the trial. So all thrombopoietin growth factors were stopped from clinical practice. In 2008, thrombopoietin receptor agonist was approved by the FDA, later by the European medicine agencies, and they were initially approved for chronic ITPs. Later came another indications for using of the TPO receptor agonist, including HCV treated with interferon or undergoing any procedures. You want to increase the platelets before the procedure. Also, it was used for severe aplastic anemia and also for chemotherapy-induced thrombocytopenia. Why did we start TPO receptor agonists? The most common used second lines, as we said, it was rituximab and splenectomy. Splenectomy shows efficacy after 2 to 5 years, long-term response in about 60% of patients, while rituximab only 20% initiate or necessitating that I have to give another dose of rituximab. The side effects were considerable. For splenectomy, we had post-operative morbidity, increased risk of infection and thromboembolism. For rituximab, we had risk of infections and very rarely, but progressive multifocal leukoencephalopathy. For these side effects, we tried to find another solution that will help to increase the platelet count and avoid all these risk factors. For that, TPO receptor agonist was licensed in the USA in 2008 as an alternative for a second line. Response rate was markedly increased, reaching about 80 to 90% with most of the patients. And the point is, for me to judge is this line successive or not, it depends upon the platelet count you are willing to reach and the risk of bleeding. If there is no risk of bleeding, then it is considered a success. TPO receptor agonists, mechanism of action. Generally, we have two types of thrombopoietin receptor agonists. We have the peptide and non-peptide groups. The peptide is mainly the romoplastin, and non-peptides is L-thrombobag, avatrombobag, and others. They will mainly target the thrombopoietin receptor or CD110 to promote platelet production, megakaryocyte proliferation, and maturation. You can see the picture here. This is the normal thrombopoietin molecule that will go for the thrombopoietin receptor, which is the tyrosine kinase, and it will dimerize, stimulating the JAK-STAT pathway and mitogen activating kinase. In the end, final results signal transduction to the DNA of the megakaryocytes to increase platelet production and will maturate and proliferate megakaryocytes. For our medications, as you see, the only peptide, as we said, is the romoplastin, and it will act in the same site of the thrombopoietin on the extracellular portion of the receptor. Meanwhile, all the other molecules that we are speaking about, non-peptide, will act on the transmembranous portion of the thrombopoietin receptor. So as we said, the indications started mainly as a treatment of second line with chronic immune thrombocytopenia, autoimmune thrombocytopenia. Recently, we are using the romoplastin, L-thrombobag, and avatrombobag that got FDA approved. The other indications include thrombocytopenia in chronic liver diseases. If you are scheduling them for a procedure or management of severe aplastic anemia, this is including L-thrombobag in high dose, 150 milligrams, as part of anti-thymoglobulin and cyclosporine regimen. Thrombocytopenia associated with interferon-based for hepatitis C. Following hematopoietic stem cells, there are trials to increase the platelet recovery after allogeneic transplant. Usually still they are not approved by FDA. Myelodysplastic syndrome, L-thrombobag was started with the MDS group, along with the linolemide and hypomethylating agents, but there was a major concern about it. The leukemic transformation, as we know, the thrombopoietin receptors are also expressed in the myeloblasts and the progenitors for myelocytes. So there was a risk for transforming MDS to acute leukemia, even though some of the researchers suggest that this risk is very minimal. But it depends on two things. If the patient is already at a higher risk for acute leukemia transformation, including intermediate 2 or high risk groups, as we said, according to the cytogenetics, then this patient might be prone to transformation. The other thing is the increased toxicity with the medication, including L-thrombobag and other agents. And it's finally was approved also in chemotherapy-induced thrombocytopenia, including avatrombobag. As for ITP response of therapy, as we said, the response of therapy, it depends on your definition of response. What is your target? Usually the thrombopoietin receptor analog, as we said, initially it can cause up to a 90% of response, but on the long term, 40 to 60 patients will maintain this response. Even though when we start to taper the dose of the thrombopoietin receptor agonist, the platelet seems to drop again. So this gives you a clue that the thrombopoietin receptor agonists are not to clear the antibodies present in the serum of the patient. It was mainly to increase the platelets and to avoid the risk of bleeding. Generally speaking, the target for me for platelet, safe platelet on thrombopoietin receptor agonist is 50,000, above 50,000 with no risk of bleeding. This is my realistic goal for ITP, chronic ITP. Okay. As we see here, different randomized studies were investigated for both thromboplastin and L-thrombobag, the initial thrombopoietin receptor agonists. But all the studies, as we can see here, were compared to placebo or to the standard care of chronic ITPs. And most of them showed marked increase in the response rate. For example, this Bucel study compared to a placebo in 6-week treatment comparing splenectomy and rituximab to thrombopoietin receptor agonists showed response rate in 75% of patients with platelet counts increment above 30,000 compared to 25% in the placebo group. Those for non-splenectomized patients. Similarly, all other studies shows more curative or increment of platelets within those receiving thrombopoietin receptor agonists. There is no head-to-head study on the thrombopoietin receptor agonist by itself, which is better or which is more effective. The studies only compare them to the placebos. Same here with the L-thrombobag. All the non-peptide thrombopoietin receptor agonists are oral medications with some of the adverse effects that I already mentioned here. You will see the common adverse effects, including headaches, nausea, fatigue. Some patients will go for upper respiratory tract infections like avatrombobag. L-thrombobag will cause increase in alanine transaminases and bilirubin. So in patients with hepatitis C or liver affection, you will be a little bit concerned about them. As for romoplastin, which is a peptide analog, the main major problem, first of all, is that this is an injectable drug, so patients should be coming weekly to the clinic to receive this medication. And the other thing, there was a risk of reticular myelofibrosis, usually mild to moderate, but in very rare cases, it developed to severe myelofibrosis. It was initially a concern about whether to continue with romoplastin and L-thrombobag or to stop them. But on further follow-up for these patients, during cessation of the medications, all the myelofibrosis degrees were markedly reversed. So it was not a very risky thing to stop the medication with the patients with ITP. Now, in Hematology, there was a review in 2019, thrombopoietin receptor agonists 10 years later. And the conclusion of this review showed that the thrombopoietin receptor agonists showed to be effective in reducing bleeding and the need for, especially if the patient is in need for concomitant or rescue medication to clear the antibodies that are present in the serum for the patient, if you want to reach complete cure for these patients. So what about thrombopoietin receptor agonists in ITP in patients with pregnant ladies? There was a multi-center study published in Blood in 2020, the use of thrombopoietin receptor agonists for immune thrombocytopenia in pregnancy. And as we will see here, ITP was in pregnancy was a challenging problem because usually these ladies will later go either for cesarean section or normal delivery. There is high risk of bleeding, and most of the medications are not that well accommodated with these patients during pregnancy. Surgeries also tend to have a risk for these patients, so they did an observational multi-center studies for patients already receiving TP or receptor agonist in this setting. Out of 15 women with ITP, exposed at least 1 week of thrombopoietin receptor agonist. 8 were on altrombobag and 7 were on romoplastin during pregnancy. And this showed that and the median time for exposure for these receptor agonists was 4.4 weeks. For safety, the mothers, the major effect was our side effect were headache, and noted in 2 patients only, with no thromboembolic events as a complication for these mothers. And as for fetuses and neonates, there were no fetal loss, only 1 neonatal thrombocytosis was noted and no neonatal deaths. So the conclusion of this multi-center study showed that overall response rate was 77%. Usually thrombopoietin receptor agonist in these patients was combined with another medications, example steroids or whatever they. So this study would suggest that we can use this thrombopoietin receptor agonist for refractory ITP during pregnancy. Seems relatively safe, but we cannot draw a final conclusion from this. Further studies are also needed to verify this risk. So what about thrombopoietin receptor agonist switching? Sometimes I start one of the thrombopoietin receptor agonists with 1 patient, and I see that the patient is not reaching my target response, or the platelets are not increasing much with this patient. Should I stop, or should I try another thrombopoietin receptor agonist? It is suggested that it's better to switch for another thrombopoietin receptor agonist. Why? Because in the mechanism of action, we saw that different molecules have different site of actions on the thrombopoietin receptor. So maybe this will benefit the patient better if you change the route of mechanism of action. Also, as we saw, some medications, some of the medication has side effects, and patients could not tolerate toxicities, or maybe like a lack of efficacy. For example, patients are not that adherent to the medication, they are not compliant to oral medications, so you will prefer to give a parenteral one or injectable one. So it's better that we try alternative thrombopoietin receptor agonists. There was a pooled analysis by Gonzalez Polaris data from 18 publications, and they signified that lack of efficacy was platelet count less than 30, and 58% of these patients had to shift from thrombopoietin receptor agonist to another to achieve the optimal response. And here are the examples. And the response rate was noted in 2/3 of the patient when we shifted. For example, here romoplastin was shifted to altrombobag in 17 patients, and altrombobag was shifted to romoplastin in 4 patients. The response rate was in 77 patients for the patients who were shifted from romoplastin to altrombobag, and 75% for patients who were shifted from altrombobag to romoplastin. Similarly, other old studies showed that there was much increase in response rate when we shifted between the receptor agonists. So take home message, autoimmune thrombocytopenia is an autoimmune disease. There is a risk of bleeding, necessitating effective management. Second line therapy is indicated after 3 months of persistent or chronic ITP, and it's composed of thrombopoietin receptor agonist, splenectomy, and rituximab. Target response is safe, platelet level with no bleeding. Therapy should be individualized as the guidelines stated, and you have to recommend rituximab. It's generally rituximab is preferred than splenectomy, and treatment with TPOs is over rituximab in the side effect wise. Thrombopoietin receptor agonist needs further studies regarding pregnancy safety, and we can shift between the receptor agonist in half of the patient if we found insufficient response. Thank you.
Thank you, Dr. Inas, for the information about the TBOs. والآن ختام هو مسك بإذن الله. The last presentation will be by Dr. Muhammad Bakar, consultant of adult hematology and bone marrow transplant. He was one of the consultants serving Jazan area since the establishment of the department. We consider him the main channel for our referral of patients from Jazan to guarantee their acceptance for management in higher centers and transplantation. Thank you very much, Mr. Bakar, for our help always, and have a nice talk.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank the organizing committee, Dr. Mahtabi, Dr. Hafid, and all the group for inviting me to be here again. I'm still a part of this area. Actually, all the speakers are, most of the speakers are from Jazan. Today I'll be speaking about stem cell transplant and sickle cell anemia and the local experience in National Guard Hospital. Actually, that's work done by Dr. Mohsen Zahrani, and all the credits go to him and his transplant group in National Guard. So I would like also to thank Dr. Zahrani for his for giving me most of the slides for his experience. Okay, this is a case presentation for a patient who is a 19-year-old male from Member. He came to National Guard Hospital, sickle cell anemia, and history of stroke. And he was in monthly transfusion and hydroxyuria. He was referred for stem cell transplant because he has right side weakness. His MRI brain showed multiple infarction, one left parietal and one in and lacunar infarction, and he has Moya-Moya syndrome. He underwent transplant in November 2015 with a conditioning that used in National Guard's combat TBI from HLA matched donor. He has almost 7 years post-transplant without major complication, without GVHD, without recurrent stroke. He has no single hospital admission, no blood transfusion, and his last visit almost 1 year. That's his data. His hemoglobin went up from 98 to 150 post-transplant. His sickle cell became negative. Hemoglobin S went down from almost 52 to 0. And his LDS normalized. That's an example for how successful could be a transplant for sickle cell patient. As you know, that's an introduction for sickle cell. I think my colleague yesterday, they give you a hint about the mechanism of sickle cell. If you take the nucleus or the cells and the chromosome, you will see the DNA helix, and single replacement of thymine to adenine will lead to abnormal amino acid sequencing, leading to replacement glutamic acid by valine. That's the mechanism of sickle cell anemia. It will lead to, of course, sickling hemolytic anemia and adhesive and also activation of coagulation cascade. They have inflammatory stimuli and white blood cell activation within endothelial cell activation, leading to platelet activation with a lot of cytokine release that lead to a sickle cell complication. Of course, there's some genetic modifier. If patient has hemoglobin F, the sickle cell anemia will be less severe. If he has alpha hemoglobin, the sickle cell will be also less severe. And of course, the African type is more aggressive. Arab Indian type is more benign. If you take a patient with sickle cell anemia at the age of 50 years, a fifth decade, that's almost 50% of them, they have end organ damage. They will have sickle cell retinopathy, they will have cardiac complication like pulmonary hypertension with left ventricular hypertrophy. They could have cerebrovascular disease. Almost 40% of the sickle cell anemia at age of 20 years, they have almost at least one silent infarction. They could have sickle cell hepatopathy, they have vascular necrosis, and also sickle cell retinopathy. That's a distribution for sickle cell anemia. Almost 300,000 baby born every year with sickle cell anemia. As you see that this is survival of sickle cell disease. Previously, it was around 10. They die at the age of 10. Then, when they start the National Act in USA, their survival started to improve with introduction of preventive penicillin at the age of less than 5 years. The survival increased. Then, after they discovered hydroxyuria, their survival also increased to 40 years. And then, when they start transfusion program, their survival reached up to 50. This is a Saudi perinatal screening program. They found that 4.2% of other populations in Saudi Arabia, their sickle cell trait, and almost 0.26% of sickle cell disease. The highest prevalence was in Eastern region, 17% are sickle cell trait and 1.2 sickle cell disease. And in the regional experience of newborn screening program that was done in Eastern region, they found that 21% sickle cell trait and 2.6 sickle cell disease. They found that initially with the starting of the screening program in Saudi Arabia, the couple, most of the 90% of the couples who declare to be high risk, they get married. With education, 6 years later, there another study found that they are getting more education. The rate of marriage from incompatible people declined to 60%. The burden of sickle cell disease in Saudi Arabia, as we said, it's almost 60,000 patients. And of course, we have in Jazan, we have the East type, the Arab Indian, which is more benign. This is the cost of sickle cell anemia. Most of the presentation I bring this slide. This is estimated cost for sickle cell anemia per age. If you find that for one life could cost 8 million from up to age 50 years. This is another study that showed the demand and how many patients of sickle cell anemia they could need transplant, and it was estimated to be almost 10,000 patients in Saudi Arabia. They might need transplant, and of course, most of the transplant centers they will not be able to accommodate. As I think the total transplant in Saudi Arabia almost 500 or 600. They use only the indication stroke, acute chest syndrome, and recurrent VOC. So they estimate the total candidate of sickle cell patient who need transplant is 10,000, 2,000 in pediatric and 8,000 in adult. This is the first transplant. This is the first report for the transplant from matched sibling donor for sickle cell anemia. It was done for a patient who was suffering from acute leukemia, who was child almost 40 years ago. And this is the first report of cure of sickle cell anemia by transplant. And after this report in 1984, the number of sickle cell transplant and thalassemia transplant increased. There is dramatic increase in number of sickle cell transplant patients. If you see, initially it was around 25 in 1991. Now it's almost reaching 400 transplant per year. This article it's a commentary. We think that sickle cell disease is benign disease, but it's not. Sickle cell anemia is not so benign. It's almost malignant disease. We think that number of sickle cell deaths in Saudi Arabia is more than the number of deaths of acute leukemia, and I think sickle cell and thalassemia death could be more than death of many cancer disease, especially in Eastern region and this Jazan. This is the mortality risk in homozygous sickle cell anemia. If we take this only single variable, if you see that patient with chronic WBC more than 13.5, they have risk of death around 10%. And if they need chronic transfusion, the risk of death reach up to 9%. High LDH, consistent high LDH more than 600 is also a risk factor for death, around 6%. If you take two variable, the sickle cell death in a patient with hemoglobin SS will increase. For example, if patient has pulmonary hypertension, TRV more than 3, the risk of death if they have high white blood cells of almost 23%. If they need chronic transfusion, it reached up to 21%. Any patient with history of sepsis, the risk of death will increase. This is, I give you just in this article, when you decide the transplant, if their risk 5 to 10%, the risk of is low. The risk of death is low. So you shouldn't need to do transplant. But if patient has intermediate or short term risk mortality up to more than 10 to 15%, of course, if they have more than 5 hospitalization, if they have more than 2 acute chest syndrome, if they have stroke. So this is generally we have to do transplant, especially with matched donor. If they have high risk mortality more than 15%, for example, if they have pulmonary hypertension with a stroke or with high LDH, this is the risk of mortality more than 15%. You could do transplant with either way, either match or hard identical. So this is a general indication for stem cell transplant. Of course, I think everybody's know it. Patient who has any CNS event, either stroke, TIA, silent infarction, patient with CNS vasculopathy, patient with impaired neuropsychological function, or a patient with abnormal MRI. Any other end organ damage like sickle cell hepatopathies, nephropathy, and silent lung disease like pulmonary hypertension. Sickle cell, I think sickle cell hepatopathy in diabetic causes is very high risk patient. And we have seen in my practice, those patients, they could die very fast, and they have to have his transplant as soon as possible. Recurrent acute chest syndrome, more than 2 despite hydroxyurea. Recurrent VOC, more than 3 per year. And the patient has multiple vascular necrosis could be considered for transplant. Other indication, priapism, patient who need regular blood transfusion, or patient who has alloantibodies. This is outcome of stem cell transplant in sickle cell in children and adults in a registry. The event 5 years, event-free survival is almost 91%, with overall survival 92%, and mainly overall survival is better in children, 95%, and in adults is 81%. That's a registry for 1,000 patients. The poor outcome in adult sickle cell is because most of the adults, they have end organ damage. They could have liver disease, they have CNS disease, they could have cardiac dysfunction, respiratory dysfunction, or sickle cell vasculopathy. The sickle cell vasculopathy, especially neuropathy, can cause risk of bleeding during transplant and stroke. Multiple transfusion lead to graft failure, and antibodies also lead to graft rejection. So the optimal conditioning regimen for adult patients should be low toxicity with low morbidity. They have long-term, durable and stable mixed donor mechanism, and they have to have low rate of GVHD. This is an NIH protocol that which they use in National Guard. This is the indication. If you see the indication, mainly they use it. That was published in JAMA in 2014. Recurrent VOC patient with the pulmonary hypertension, CNS disease. They went in transplant from match with a sibling. The conditioning regimen was alemtuzumab, 1 milligram per kg. They start day -7 to day -3. Then 300 TBI. Then they use peripheral ameliorated peripherally collected stem cell. And GVHD prophylaxis alemtuzumab with sirolimus. This protocol was overall survival reported as 94%. There was 1 death because of intracranial hemorrhage. The disease-free survival was 88.5%. This protocol was applied in many centers, and if you see that the GVHD rate is very, very low, almost zero in most of the studies, and in our experience in National Guard, there's only 3 cases, and it was mild GVHD. And the mortality overall is low. Overall survival was 97%. 100% in this protocol showed mixed chimerism, and of course, mixed chimerism in patients with sickle cell anemia post-transplant is, if you have more than 20% mixed chimerism, it can be enough to be transfusion independent. So overall survival was 97%. Graft failure is ranging from 3.3% up to 13%. Mortality from 2.7 to 3%. Sustained mixed chimerism is sufficient to cure. This is another study showed that if you have patients with sustained mixed chimerism, they could have, they will not have recurrent of sickle cell disease. The donor RBCs usually have longer half-life, they have low hemolysis, and they will decrease the effective rate of uses. This is the overall survival and event-free survival patient who went in transplant in National Guard Hospital. That was published in bone marrow transplant in October 2020. The event-free survival was around 97. The overall survival was around 97%, and almost 100% in pediatric, and in adult was less. This is the experience for transplant in sickle cell anemia in National Guard. That's, of course, work of the group. It's not me. I just start there. Dr. Mohsen Zahrani, he's a leader of sickle cell transplant in National Guard. So the total number of transplant was almost 229 patients. They did 219 matched sibling transplant. There's 2 patients with mismatched transplant, 9 out of 10, and only 8 patients have the identical donor. The genotypes, most of them, 73% are sickle cell hemoglobin SS, and 23% hemoglobin S beta thalassemia, and 1 patient with hemoglobin SD disease. The donor type, we could say that 60% of the donor was they are carrier for sickle cell, and the comorbidity index ranging from 0 to 2. The indication for transplant, mainly CNS event, CNS crisis, patient in 24%, recurrent acute chest syndrome in 8.7%, recurrent VOC or vascular necrosis, recurrent parabism in only 5 patients, and the transplanted patient who was in dialysis. They transplanted 6 patients who was in dialysis, and most of the patients, they have 2 or more indications for transplant. This is the program was started in 2015. This is published in the Blood 2020. Total of 110 patients at that time. The event-free survival was 87%, and overall survival was 97%. The median follow-up around 62 months. There was 3 deaths because of graft failure. You see, this is a post-transplant chimerism. Most of the patient, if you see 1 month, you have highlighter here. Highlight. Okay, excellent. So this is a post-transplant chimerism. If you see 1 month, you can see that the chimerism increase up the myeloid chimerism from 60 to 80%, and most of the time sustained post-transplant. And if you see hemoglobin S drop after 1 month of transplant to 0 or 20% according to the donor, either carrier or not, and their hemoglobin improved post-transplant and almost normalized. This is a hospital admission pre and post-transplant. Of course, pre-transplant, most of the patients, they have frequent admission. Post-transplant, most of the patients, they don't have admission, average 3 to 2. At day 100, they don't have really, after 1 year, most of the patients, they don't have any admission. Hemoglobin pre-transplant, 8 to 9, and post-transplant improve up to 12, and some patients reach up to 13 to 14. Hemoglobin S level pre-transplant 70%, drop after 100 days to 10 to 20% according to the carrier. Transfusion burden during transplant also improved. ER visit decreased significantly. The most important, this is the graft details and graft failure among 216 patients who went to transplant. They used CD34, 13, around 13, and engraftment neutrophil platelets. Median neutrophil engraftment was 17 days, and median platelets engraftment was 16 days. And most of in 119 patients, platelets was never less than they didn't have nadir platelets. The graft failure is almost 17, equal to 7.8%. For primary graft failure, and 13 was secondary graft failure. And time to graft failure ranging from 40 days to almost 2 years or 3 years. Outcome of post-graft failure, of post-transplant graft failure, either 41%, 7% they have recurrent sickle cell disease, and 10% they have aplastic bone marrow. 11 out of the 17 underwent second transplant, 7 of them they are sickle cell disease free and alive. So out of this 17, out of the 17 patient, 7 patients survived. The mortality around 8 patients. Cause of death mainly graft failure in 5 patients, and other transplant-related mortality is 3%. Time of death ranging from 40 days to 500 days, and so overall survival was associated with mainly with overall survival. It was with and without the graft failure. It's almost reduced. So if patient doesn't have graft failure, their mortality is more than 98%. And if they have graft failure, mortality overall survival dropped to 78% to 74%. This is a protocol they use it in National Guard just to reduce the risk of graft failure. They will choose the most compatible donor, and they will try to avoid, if patient has RBC allo antibodies, they will try to find another donor. And if the donor has allo antibodies, they will use either rituximab or Blix. If a patient has major OBO incompatibility, they use rituximab and Blix. And if and they proceed the transplant if the titer of the titer is less than 1 to 32, and they have to consider hydroxyurea, the maximum dose. They increase the CD34 dose to up to 10 millions to optimize and optimize serum level. That was the maneuver to reduce the graft failure. The complication post-transplant, GVHD was only in 3 cases, all mild, grade 1 to 2 in mainly skin, and all resolved with local therapy. They didn't need systemic therapy. The VOD was 0. 2 patients developed breast, and no patient developed TMA. The hyperglycemia is a side effect of sirolimus in around 5 to 10% of the patient. Hypertension and proteinuria because of sirolimus in 6% of the patient. And also autoimmune hemolytic anemia was reported in only 5 cases, and also it was secondary to sirolimus. Infectious complication, CMV, 25% of the cases. Epstein-Barr virus in only 1.8% of the cases. 3 cases developed B19 infection, and 5.4 death, the basal zoster infection, and they developed after 1 year of stopping the acyclovir prophylaxis. And invasive fungal infection in only 6 cases. So that was an experience in National Guard for match-related sibling transplant. This is, if you don't have donor, you will struggle to do the transplant either from match-related donor or haploidentical. This is the outcome of match-related donor most of the study. It's associated with significant chronic GVHD. Sometimes could be an extensive up to 40%. So a match-related donor transplant for sickle cell anemia is not recommended in general, unless patient is high risk. And I don't think that we did it in National Guard. For haploidentical transplant, now there is a way to overcome the GVHD either by T-cell deplete post-transplant cyclophosphamide or T-cell deplete ex-vivo T-cell. So T-cell deplete post-transplant, you just, of course, after antigen presentation to alloreactive T-cells, the proliferation day 3 to 4, they give cyclophosphamide. That's will kill the T-cell lymphocyte and will decrease the GVHD. This is moving. T-cell deplete ex vivo ex vivo, they can either you can do CD34 selection, or you deplete CD3, and you do graft manipulation by CD45 R depletion. Then you give the graft. So this is a protocol of Johns Hopkins for haploidentical transplant. They use flow site, TBI, ATG, thermos for patient who's going for haploidentical transplant. If you could see it, it's a bit complicated. There's ATG, then flow dropping with cyclophosphamide in day-6, then TBI and TBI 200. And after transplant, they use post transplant cyclophosphamide as GVHD prophylaxis. And they use I don't know why this is. They use either tacrolimus for transplant. This is protocol. This study is almost done now in 12 centers in Saudi Arabia and USA, UK, and Netherlands. I think we share it with King Faisal Hospital also. They use the Johns Hopkins protocols with adding 30 to ATG with fludarabine, cyclophosphamide, and they use bone marrow harvest as a stem cell source. It has been reported that the 15 patients that have severe sickle cell disease, overall survival was 100%, event-free survival was 93%. This is me moving along. I'm sorry, the slides is moving along, so. So what they modified in the study, that just add 30 to the protocol, and they use 400 TBI instead of 200, and they use a non-mobilized bone marrow source. So both sides have identical transplant. They have minimal GVHD, and they improve outcome. And when they add 30, it decrease the graft failure. So this is the study. They use flow-cy ATG and TBI 200. When they add 30 to 15 patients, they decrease the rate of GVHD and decrease the graft failure. Their overall survival, despite being haploidentical transplant, which is considered high-risk transplant, the overall survival was almost 100%. And the rate of GVHD is very low. Chronic GVHD almost 4.3% in most of the study. This is another way you could do a T-cell deplete haploidentical stem cell transplant by using CD34 selection. And again, the acute GVHD is ranging from 25 to 29%, and chronic GVHD they have up to 12% and 23% in some studies. National Guard experience in those study, when they use haploidentical transplant, they did it for almost 10 patients until now, and they used CD34 around 6.4 millions, and engraftment of neutrophil and platelets almost in all patients 100%. Median neutrophil engraftment was 19 days, and median platelets engraftment was almost 29 days. So because of its bone marrow harvest, the engraftment will be longer, but they use again Thiotiba, ATG, Flow-Cy, and TBI, followed by cyclophosphamide, a high dose for prophylaxis, and Seromas with MMF as GVHD prophylaxis. The mortality was only one out of this 10 patient. The cause of death was infection, renal failure. So this is a pathway to transplant to National Guard, pathway to refer to transplant to National Guard. The patient source mainly referral from all centers. They have first visit. They do a first visit to transplant center. They start donor search, and then second visit then we prepare for transplant and transplant admission. By the way, now we start the outpatient transplant program for sickle cell anemia, for multidisciplinary. I think 4 or 5 patients, they start allotransplant sickle cell as outpatient. Those 3 cases are urgent: sickle cell hepatopathy, pulmonary hypertension, and stroke. So feel free to refer those cases, because sickle cell hepatopathy, especially, they die very fast if you didn't do transplant. And I think we have case. It was referred from our center, from Jazan, from our center here to National Guard. His bilirubin was around 700 and almost encephalopathic. When we refer him to transplant, the hepatobiliary was reluctant to do a liver transplant, and they proceed with the transplantation. His bilirubin after transplant went down from 700, 600 to normalized, and was normalized after transplant. During infusion, he developed just hepatic encephalopathy, and he recovered totally. So even high bilirubin and sickle cell anemia, those protocol come back TBI, you could use it for patients with sickle cell hepatopathy. But those patients who develop, I mean by sickle cell hepatopathy is intrahepatic cholestasis, not because sickle cell hepatopathy is broad name for most of sickle cell hepatobiliary complication, but intrahepatic cholestasis is very fatal, and you have to do a transplant as soon as possible. And without transplant, most of the patients, they die. Pulmonary hypertension and stroke, those are urgent cases. That's required. That's medical report, 2 ID, 2 contact number. And in conclusion, there is still limited number of transplant center and priority only for patient approved indication. I think rejection rate now has been, now patient has no indication for transplant. They usually reject in National Guard. And there is misconception. Transplant has its own complication, and not all patients should do the transplant, because many patients, many sickle think that transplant can cure them, but still it has its own risk, still has mortality. So it's not. I got called from many patients sickle cell who's doing well in hydroxy. They ask for transplant. I think we should minimize a referral for patient who is stable in hydroxyurea, and patient should receive maximum dose of hydroxyurea before he referred for transplant. Transplant in young age, they could tolerate non-myeloablative conditioning, RIC, and acceptable outcome in adult patient with RIC. Haploidentical transplant could be a next door choice for high-risk patient. And that's the last slide. If you have any questions, you're welcome. Thank you.
Thank you, Dr. Mohammed Bakar, for sharing the National Guard Hospital experience in sickle cell transplantation. And it is time for any question for Dr. Inas. So I think it's not here. Yeah, Dr. Gad will ask.
My question to Dr. Saud, we have multiple patients with comorbidity, older patient who are ineligible for transplant, and we are hoping to send them for CAR T-cell. But what is criteria, like patient who is equal 4 or 5, you are accepting such patient, or only equal 0 and 2 like this?
So still it's not a standard of care. So it's a clinical trial what we have. Basically, you have to have ECOG 2 or less and good organ function. And we have a few availability for those patients. So still not yet a standard of care. It's a clinical trial for a CARTITUDE-2 phase 2 trial. And you have a patient has to have good organ function with good performance status. And the induction has to be DRD for 4 to 8 cycles. And they have to achieve very good partial response or more. So it's a
there is an inclusion criteria for this.
So for if the patient we want
Front.
you are hearing me well? You are hearing well? Okay. So if the patient is not meeting this criteria, we will not start for him DRD from the start.
No, still DRD is recommended as a front line.
As a front line.
Yeah, so
whatever he's going for, you mean
CAR-T,
for
regardless
or
of
not?
CAR-T or not. So the lady I show you, she is not a CAR-T cell candidate, but we started on DRD. So it's very well tolerated, very rapid response, and we haven't seen a lot of toxicity with this treatment.
Okay, but some patients they are not willing to come to the hospital for
So this is another option.
Okay, thank you.
That's why I give you another option is just to give Revlimid Dix for 9 cycle, then shift to Revlimid maintenance for those who are not willing to come or they have side effect with daratumumab.
Yeah, so I have a number of questions to all speakers. So I'll start Dr. Saud. So in my trial, so if you have a patient with impaired kidney function, or let us say on dialysis, and you want to give all my question is that DARA based or anti-CD38 based therapy. So you want to give monoclonal antibody based therapy for these patients. So patient number 1 is the patient with impaired renal function. So how would you dose this patient?
So it's a tough question. Daratumumab, all clinical trial with Dara, frontline, relapse refractory, all the GFR was more than 30 at least. However, there are a lot of case reports for patients who are on dialysis and showed effective and tolerated. I haven't given any patient on dialysis daratumumab. I usually prefer VCD for those who are very impaired kidney function. So I would go with VCD.
Then I did give it was very well.
Huh?
I did.
You did Dara?
Yeah.
So I haven't given any Dara, but it's been reported a lot of case report that it's safe and as effective as those who are with good renal function.
And another issue, if you want to give Velcade, with Dara, or with isatuximab, for example, isatuximab study, the Velcade was given twice weekly. I never give twice weekly Velcade. So what you will do?
So, the SWOG trial is given twice weekly, the initial, but no one is moving. Even I've asked Vincent Kumar, Raj Kumar, they said we're not doing twice weekly anymore. Once weekly is better tolerated. Patient has to come only once a week. And even less neuropathy with this once weekly. So no one now is using twice weekly, but the original trial is twice weekly, the SWOG trial.
Okay.
I have one patient she was really very well educated. She said, treat me the same as the trial. So I give her the twice weekly, but we don't use it usually twice weekly.
So the last question is the duration of therapy for transplant ineligible patient, Dara-based therapy. So for how long you will continue treatment?
So it's based on the study, it's continuous until progression of disease or intolerability. So that's what we are following this until progression of disease or intolerability. And once a month daratumumab is acceptable for patients who are living from outside, that I have a few patients with DRD, all of them, they are none from, they live outside Riyadh. So they're suffering. So the first weekly, they said we have to rent. So I gave them the option of RD, VCD. We used to give the Velcade to the patient, but now with this limitation of drug supply, we don't give it anymore. So we used to we give Velcade at our infusion, then we give them 3 doses to be given locally. However, with shortage of supply, we're not doing it anymore because now patients are sharing the vial, because the vial comes with 2.5 milligrams. Some patients receiving 1.2, 1.4, so they share the same vial. So if they are not willing to stay, other option is available, including RD or all of them. They decided to get the best available therapy, and they rented. Unfortunately, they have to rent
an apartment because it's a weekly for 2 months. They said we cannot go and come back from Arar or from Al Grayat every 1 week. It's not it's not logic.
There are small centers now in most of the regions. They could cooperate with you and they give Velcade for your patient. Yeah, I think most of the RR, even RR, they have their small centers.
Believe me, I have patients from Al Grayat. None the private clinic, they refused to come. So he was transplant eligible. So he had VRD for 4 weeks, followed by an private center, they refused to give. Governmental, they refused to give Velcade. So he was flying every week from Grayat to get Velcade. So sometimes, and even logistic arrangement, I have done it with one patient with carfilzomib to Abha initially, that few years ago. It's a lot of headache. So you reach a point, you said, you get it here or forget about it.
Thank you. So if you allow me just more question, Dr. Muhammad and Dr. Muhammad, for Hablo protocol, I know you do bone marrow harvest, but sometimes donor will not consent for harvest. He will consent for peripheral blood. In our center, we do have low from peripheral blood for leukemia, I mean, not for sickle cell. But do you have any experience in your center with the peripheral blood Hablo for sickle cell?
They do it bone marrow because it's study protocol, and I think they run the study protocol. I think King Faisal, Riyadh, they have the same study. So most of Hablo identical transplant, they do bone marrow harvest. But for leukemia, we do it preferably. Leukemia.
Okay. Right. Last question to Dr. Inas, and actually a very nice presentation. I want to ask about duration of do you have any experience of patient that you are able to stop thrombobac or
some patients we started with the thrombopoietin agonist receptor agonists, but as soon as you de-escalate the dose or you stop the dose, the patient will stay for a few weeks and then he will relapse again. So you will have to reinitiate the dose or consider changing the line or even starting third line treatment. We sometimes add azathioprine or cyclosporine or whatever available to reduce the risk of severe thrombocytopenia and bleeding with them. And patients who did not undergo splenectomy are considered for splenectomy.
Thank you for the nice presentation. My question to Dr. Bakkar, I'm talking about the non-urgent cases, sickle cell disease patients. We know we are on the era or even on the verge of the approval of gene therapy. The papers are under review by the FDA, and soon, I think by the end of March, they will declare whether this is accepted approach or not. Would you, if like one of your relatives is a sickle cell disease patient, would you advise them to wait till the gene therapy is approved? Because it is like an autologous stem cell transplant, no GVHD and no other complications in comparison to the allogeneic stem cell transplant. What will be your sincere advice?
If patient actually, it depends if he has acute chest syndrome 2 times or 3 times, high-risk disease, I would advise for transplant. I believe that, for example, patient who has developed septic shock and he required ICU admission, this for me and from my experience in Jazan before I moved to National Guard, this patient should do transplant and advise them to do transplant because next time his sepsis will be different. And we've seen it a lot. When you have patient with acute chest syndrome 2 times, 3 times, or patient has high-risk disease, pulmonary hypertension, I would advise them to do transplant, even if my relative. This is my approach. Other patients like VOC, mild VOC patient, only one vascular necrosis, they could wait for gene therapy. But the gene therapy, if it's come, I don't think that it'll be soon in Saudi Arabia. We have a lot of patients. It's very costly. I don't know how much it costs, but I don't think that. I think that sickle cell transplant now they do very well by either protocol, either combat TBI or Flu-View ATG. They do very well.
Just question to Dr. Muhammad. As you mentioned here, for urgent referral as the cause of transplant is pulmonary hypertension. So what is this according to the grade of pulmonary hypertension by millimeter HG pressure or by TRV, according to the severity or clinical manifestation of the patient? What severity that we can refer the patient urgent for transplant?
If patient has TRV more than 3, there's an indication that pulmonary hypertension and he needs transplant. I think tricuspid regurgitation velocity more than 3 is enough an indication for a transplant, and you could refer them because those patients is high risk. If patient has severe pulmonary hypertension, also is an indication to send them as soon as possible. But because you're doing echo for most of the patient, you might find asymptomatic patient, he has only mild shortness of breath and exertion. You might be reluctant to refer them, but if patient develop pulmonary hypertension, the risk of mortality is very high. It's up to 20% in some cases. So early transplant is better.
Okay.
No more questions? Okay, by this we got the last session and we finished all the audience and the speakers. Dr. Hafid will come to finish the so at the end of this conference, I would like to thank all attendees and either physically or virtually. I'd like also to thank all speakers, especially those who came from another areas. Also, I'd like to have great thank for Dr. Hafid for his great support for this conference. Thanks to Eventropes and thanks to all sponsoring companies. And I wish we can see you inshallah next year, maybe more frequent than once a year, and better arrangement inshallah. So at the end I will thank all of you. قبل ذلك أيضا نشكر الله سبحانه وتعالى أن يسر هذا الأمر، والحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. جزاكم الله خير.
جازان يا ضرة الجنوب الباسي من ناعم الخصيب جازان يا ضرة الجنوب الباسي من ناعم الخصيب لكل قلب إليك شوق مطمخ من هوى وطيب جازان يا البحر والصخر فيك يسمو بنشوة السحر في الغروب